Okay.
Sir, it's 3, 2, 1. We are live to the audience. We can start this meeting. Over to you, sir.
Good evening, friends. On behalf of the Tamil Nadu Ophthalmic Association, as the president of the TNOA, I have the greatest pleasure of welcoming you all for this 14th TNOA ARC PG Catalyst Masterclass on Surgical Retina. Friends, I took over as the president of TNOA in September 2021 during the Madras Icon Conference. And since then, it's been a roller coaster ride for the entire TNOA. The flurry of activities which are done, not only in the academics, but also in other aspects as well, has taken TNOA to a greater height. I cannot take the credit myself because it's the entire team of TNOA, the entire team of office bearers, like the president-elect, the vice president, secretary, treasurer, and all chairman ARC, and all other office bearers who made a huge difference as far as the academic activities and reaching out to postgraduates, residents, fellows, and the practicing ophthalmologists as well. The theme for this year was Tamil Nadu smiling and TNOA shining. And for the past 11 months, we have been doing exactly that. We started the TNOA Masterclass way back in October with an optics and refraction by Dr. Vijayaraghavan and Dr. Chandrasekhar. And since then, every month we've been having a masterclass covering every subspecialty of ophthalmology, which is useful to the postgraduates, residents, fellows, and the ophthalmologists who are practicing across the country. And this ARC masterclass, which has been supported by the Milmet, I have to thank the Milmet people for completely powering this ARC masterclass, which is actually a wonderful concept, which has benefited a huge number of ophthalmologists across the world, I would say. And every masterclass is being logged in by at least 1,500 to 2,000 people on the TNOA YouTube and the Facebook as well. The entire credit goes to our chairman ARC, dynamic chairman ARC, Dr. Rajshekhar, who has been the guy who was instrumental in getting all these masterclass, coordinating with various faculty, and making sure that the topics which are being discussed in this masterclass are very appropriate for the postgraduates and the residents who are going for the exams. Having said this, the masterclass is not the only activity which is the TNOA has been doing. The TNOA Connect series, which occurs on the last Sunday of every month, it connects all the major institutions across Tamil Nadu. And as you all know, all the major institutions, Tamil Nadu is the mecca of ophthalmic education. And I got in the concept wherein I should connect all the major institutions in this Connect series. The Connect series with the main objective of benefiting the practicing ophthalmologists with various important topics, clinical topics, like cornea, glaucoma, oculoplasty, and every subspecialty has been covered in this Connect series. The last of the Connect series is on 31st July, and I'll be signing off on that day with the refractive cataract surgery with Uma Eye Clinic, Dr. Arulmozhi Varman. So the masterclass, the Connect series actually connects the various institutions like Arvind, Shankar Netralaya, Agarwal Eye Hospital, Eye Foundation, Rajan Eye Care, Arasan Eye Hospital, TMS Eye Hospital, and various other institutes, Shankara, Coimbatore, and all these masterclass, the Connect series, were able to connect. And because of that, we are able to get the combination of expertise from not only the institution, but also from outside. And this is a wonderful concept which has been appreciated by one and all across the country. And because for my elections, I've been traveling throughout the country, and all the people have appreciated all these webinars of TNOA. I'm very, very grateful to all the members for this, for the constant support, which has made these TNOA webinars very popular. In fact, everybody is looking forward to the TNOA ARC Masterclass, which occurs on every second Friday of every month. Then we have the most popular, I would say, the Walk the Talk series, which has become very, very unique. The Walk the Talk series, wherein we interview or hear the success story of the luminaries of TNOA who have set a very, what you call, trailblazing path for everybody to emulate. They have been the role models. They've been the source of inspiration and motivation for all of us. And when we started this Walk the Talk series, everybody was telling me, no, everybody will have the same success story. But you would be, to my surprise and to everybody's surprise, people have listened to this Walk the Talk series, which is also available on the YouTube. Every series has been, every Walk the Talk has been, every luminary has given us a different perspective on how to attain the pinnacle of success. There are several routes to pinnacle of success. And we learned it from the masters, from the luminaries. And tomorrow we are going to have the grand finale, the Walk the Talk series with none other than Dr. Panneerselvam of Varasanai Hospital, Erode and past president of TNOA. It is going to be a physical meeting. It's going to be a hybrid meeting. And we thought we'll finish off, have the grand finale of this Walk the Talk with a hybrid meeting at Erode tomorrow at 8 p.m. Everybody is welcome for this meeting. We are looking forward to having a very good meeting and also very good fellowship after the meeting as well. After a long time, all our TNOA members are going to gather. In the month of April, we had a very, very unique concept. The first time ever, we brought this, what is called Gurukulam. The Gurukulam TNOA, a concept which has been brought up by Dr. Chandrasekhar and Dr. Vijayaravan, the two pillars of ophthalmic teaching in Tamil Nadu. They brought this concept of Gurukulam, wherein all Sundays of April of 2022, from morning 8 o'clock to afternoon 1 p.m., we had 26 different specialities or topics covered by 19 top faculty from across India. Very, very popular. Everybody, all the postgraduates appreciated the amazing feedback I got with Gurukulam. We wanted to do it for one more month. But unfortunately, we didn't have the time to do it. And again, we are waiting for the next conference. Probably the next president, Dr. Ramakrishnan, will definitely take it over and do it again in the ensuing year. We are also looking forward to a great conference, physical conference. The first time ever after 2.5 years, the Mask Off Conference, that is COVI 2022 in an amazing venue, Kodisia. Everybody knows that venue in Coimbatore. Already 1,500 delegates have registered for this, more than 1,500, I would say, for this wonderful conference. Chairman Scientific Committee, Dr. Satyan, has done a wonderful job in compiling a very good scientific content. And of course, organizing secretary, Dr. J.K. Reddy, is doing a wonderful job. The Coimbatore Society of Ophthalmic Surgeons, CSOS, have been doing wonderful work to make this conference a very big success. So as a president, I would invite you all for this conference as well. And for the other activities of TNOA, you can log on to our website and see how exactly we have fared this year. I'm sure the next president and the following presidents also, and the following team is going to take over and take TNOA to greater heights. With these few words, I hand over the proceedings to Dr. Rajshekhar. I have to say a few words about Dr. Rajshekhar, the chairman ARC, the professor of ophthalmology in RAOGOH, and wonderful work he's been doing as a chairman ARC for the TNOA. Constantly doing this is not easy, and having it done on every second Friday of every month for the past almost 11 months, we have had 14 master classes, and all these master classes have been a huge success because of the excellent faculty like you. It made the difference. And of course, the two masters today, I call them, they're like Sachin Tendulkar and Dhoni, as far as Tamil Nadu Ophthalmic Association is concerned. The two Gopals, Sriram Gopal and Mandana Gopal, the two course masters, they are really masters, they feel. The amount of inputs they are giving for TNOA, Mandana Gopal as well as Sriram Gopal, as a joint secretary, has done so much of work. Really, hats off to you, Sriram, for doing so much of groundwork and getting all
Thank you, sir. You flatter me too much. Thank you so much.
Yes, sir. But Mandana Gopal also, we started the program called the Publish and Prosper. And the Publish and Prosper, every peer-reviewed publication of the TNOA member, we were giving them 2,000 rupees cash citation of cash with a gold medal and a citation. Till now, more than 60 people have benefited from this. And the concept is from Mandana Gopal. And thank you, Mandana Gopal, and also many other programs Mandana Gopal has been helping me in sorting it out. Over to Dr. Rajshekhar to introduce the moderators for this program. And another moderator is Dr. Vijaya Shanmugam, who is also here with us from Madurai Medical College. And he is also a wonderful teacher. It's great to have Dr. Vijaya Shanmugam also here. Dr. Rajshekhar, over to you.
Vanakkam, sir. Vanakkam. And how much satisfying and how much beautiful this journey had been. As our president, Dr. Mohan Rajan, pointed out in his own inimical way, there was not even that many calendar months to conduct this much of ARC meeting. The calendar months which we had is lesser, and the mileage we got and the distance we covered is too much. In fact, the whole gamut of ophthalmology had been explored. To an uninitiated student, if he had stayed with us through these 14 programs, or he can stay with us in the virtual media, which is where it is always available, then he can go through all these programs and forever get benefited, because all these programs are gems of their own kind. I believe that the whole concept of TNOA ARC Masterclass had metamorphosed and evolved and organically grown. And I wish that with MR and as I am also outgoing, I wish that the future team will take this up and continue it and add value to it in their own way and make it more beautiful and more acceptable to our student community. In fact, only two things I want to say. The point number one is the success of every program. We have had programs where people have spoken from the US. We have had programs where people have spoken from the North, and people from everywhere, the master trainers. In fact, the two competition for this success of this program is, one is the topic that was very much affectionate to the students, very much relevant to the students. And I believe the topics is what kept it grounded. The whole concept of ARC Masterclass was grounded and could continue month after month and become a brand of its own because of the topics. And the master trainers are the people who gave it wings. They gave it the beautiful flair and arrangement, which kept the students enthralled And as MR pointed out, we have almost 1,500 click-ins into all our virtual programs, all the 14 programs which are there on internet. And I strongly thank Milmet for arranging this in a seamless fashion and keeping it very clean and neat. And the programs have only one essence in common: the age-old teacher to student personal connection. That is what we are giving. Each topic will be taken for 20 minutes, 25 minutes, 30 minutes even, where the teacher, master trainer will have his own student in front of him, and to him he starts speaking, and in that process, thousands of students benefit. With these few words, I thank the President-elect, Dr. Ramakrishnan sir. We sincerely believe he had always been with us with these programs, and I sincerely believe that he will take it up and take it further. We have most of the office bearers who are always with us in this program, and I wish and hope that they take this up and continue it for the future. With these few words, I take pride and privilege in announcing this master class, which is going to be on surgical retina. We have already had a master class on surgical retina, and surgical retina is one thing where we never have enough. So we have it once more. And this time we have moderators, Dr. Sriram, and master trainers, Dr. Sriram Gopal and Dr. Madana Gopal. And the array of topics which has been lined up for Dr. V.R. Saravanan, it's a curtain riser on VR surgery, just to initiate people into VR surgery and to make them understand that it is a totally different ball game than any other surgery like cataract. That is going to be done by V.R. Saravanan. Dr. MPS, we are very proud and honored to have MPS with us, and he's going to tell us about the whole gamut of managing, receiving a patient, working him up, diagnosing him, and managing him when he has a regardie. And Dr. Chetan Rao from SN, he's going to speak to us about proliferative retinal diseases. I now hand over to Dr. Sriram to further detail and yes, sir.
Raja, this is the first master class on surgical retina. The
We
earlier
have had
was
one, no?
Connect series.
No, that was
yeah,
Connect series. That was
So,
not surgical.
that's what I'm trying to say. The Connect
we
series is
had it on the
different
Connect series.
from the master class.
Yeah.
In fact, I was talking to Madana Gopal. See, the master class is mainly for one or two people who speak, and it is mainly for the postgraduates.
Yeah.
Start with the Connect series is more for the advanced level.
More for that.
So yeah, so it's totally different.
Yeah.
And Pramod Bande, I just got the information message from Pramod that he's out of India. There is a doubt whether he'll be able to join, but he said he will try his best. But however, we'll go with the other one. Okay.
Yeah.
Go to
Dr. Sriram to introduce the speakers and to go ahead.
Good evening, everybody. Good evening, dear President, MPS sir, and all friends. I've been actually given a very easy job today. 3 very, very well-known, renowned VR surgeons. I don't think they need any introduction at all. So it's made my job very easy. We'll first start off with one small disclaimer, actually. I don't think me and Madan are master trainers in this audience. I think we are also 2 students eagerly waiting to listen to these people. So it will be more appropriate if those 3 are called master trainers, for lack of better terminology.
Master students, maybe.
Yeah, master students, maybe.
The master students who become masters their own way.
We are trying to masters.
Because of the super masters who are there on the faculty.
Yes, sir. So we'll first start off with Dr. Saravanan, V.R. Saravanan, who's a senior VR surgeon in Arvind Hospital, Coimbatore, a pretty well-known person, and what shall I say? Probably in the whole of Eastern Tamil Nadu, anybody has any surgical VR problem, I'm sure immediately they pick up a phone and call to Saravanan. Such an approachable and amicable guy. That is the most important thing. And he's always ready to sort out your problems. And he is very, very, actually, I've been under him as a postgraduate when he had just become a medical retina consultant. I don't know whether Saravanan remembers in 2001 July. So Saravanan is actually a very good teacher in the sense he always comes down to your level. He comes down to your level and teaches it in a way you understand. So that is a hallmark of Saravanan. We are very eager to listen to Saravanan. I don't want to keep the audience waiting anymore. Over to you, Saravanan.
Thanks, Sharon. Just share my. So when Madan first gave this, he said that he just gave me a list of questions which commonly asked by the postgraduates, and told me to sort of address this so that they can understand the concepts, basic concepts of. I think Mahesh sir and Chetan will be talking about the other disease related topics. I'll be just talking on the fundamentals. So mainly when you talk about the VR surgery, we are talking about mainly the vitreous, which is even though it is it's not equal to, even though it fills most of the eye, it's not like aqueous. So it's more like a gel form where the content is not plain water. It got a lot of collagen fibrils which are there. So it's like a chicken noodle soup. If you want to remember the this Kung Fu Panda movie, it's not like a routine normal soup. It has got a lot of noodles inside it, and removing that, it cannot be removed with a plain suction. So for David Kushner, he was the first person to perform open sky vitrectomy. So what he did it with the sponge and scissors by using scissors to cut it, and that's what was the water, because it was not like a fluid. You cannot just aspirate with the Simcoe or just a suction cannula. That's the main important thing which you have to understand here. So keeping this in mind, Robert McKimmer, he first devised the whisk device, which was the proper vitrectomy. It was like a guillotine-based cutter. So it had both the infusion and the cutting in a single probe, and the illumination was done by the indirect ophthalmoscopy. And at the same time, we had Dr. Payman. He also devised his own cutter, and associated with Retina Associates Limited. But because McKimmer was the first to publish, he is sort of credited with the invention of the first vitrectomy machine. So because then later on we had the light pipe also incorporated in the same instrument. So the gauge of the instruments, or the size of the bore of the instruments, was too large, and we had to make a large opening, 17 gauge, very big opening in the sclera to accommodate this big instrument. So to make the ports smaller, modern vitrectomy has sort of isolated each of these functional components. So one is the infusion, where we have the balanced salt solution irrigating the vitreous cavity, and then you have the light pipe, which sort of illuminates the fundus, and then we have the third port for the vitrector, or the cutter, which is used to cut the vitreous. So now the modern vitrectomy, to make the opening smaller, and also other advantages of separating all these components. So we have now a 3-port vitrectomy, and sometimes we use bimanual technique where you use scissors and forceps in both hands, and we have a 4th port to keep the chandelier light in situ. So now we have either 3-port or occasionally 4-port vitrectomy for more difficult cases, compared to the initial generation, which was a single-port vitrectomy. We talk about the type of cutters. I told you it's because chicken noodle soup, we have to cut the noodles. So we have 2 types of cutters: the rotary cutter and the guillotine cutter. So more commonly, the guillotine cutter is the routinely used cutter, because the efficiency of the guillotine cutter is much more greater, so that there is no traction on the noodle, so that you can cut it off very easily. In the guillotine cutter, you have an outer bore and the inner bore, which falls up and down, cutting the sucked noodles into the vitreous strands into the suction pulls the vitreous strands into the inner bore, and as the inner bore falls down, it cuts the vitreous gel. So it is like a guillotine, means which the machine which is used to behead prisoners in the olden day European prisons. That's what we call as guillotine cutter. The rotary cutter, we have an inner tube which has got an opening which sorts of rotates within the outer tube. So here, even though the speed achieved is much more higher, the efficiency of the cutting mechanism is not that very great. So there's a lot of drag on the vitreous that leads to more traction on the retina, which can be harmful, and we can have retinal injury. So the rotary cutters are not that very preferred, even though they can achieve higher vitrectomy speeds. And guillotine cutters are more preferred because of their efficient cutting action. We talk about the fluidics in the vitrector. We have, as you can see here, these are the main components which enhance the efficiency and as well as the safety of the vitrectomy cutting inside the eye. So the cutting speed at which the guillotine moves up and down, the aspiration, meaning this vacuum which is used to suck the vitreous into the tube, and also the size of the bore. Now we have the micro-incision vitrectomy system, and then the concept of duty cycle, which is a little bit higher for pitch, but just touch upon that also. So this is how a vitreous cutter looks inside the eye. You can see this is Apple's view where the vitreous cutter is inside the vitreous cavity. What you see at the top is the lens. And here you can see when the suction is less, the retina getting pulled into the cutter also is lesser, so it's a little bit much more safer. And when the suction is increased to 400, as you can see in this, the chance of injuring the retina becomes high, because as you can see now we have an accidental tear in the retina. So as you can see, so the three components are very important. When the cutting speed is very high, it is much more safer. When the aspiration is low, it is much more safer. And the size of the bore, when it is smaller, again, it is much more safer to do vitrectomy. I'll show you why. So this is the slide showing the how the mobility of the retina when you cut. So when the higher the cutting speed, lesser the mobility of the retina, the lesser chance of injuring the retina with accidentally during vitrectomy. And you can see here the movement of the retina with the higher suction and lower cutting. So the lower the cutting, it is very unsafe. Higher the cutting, it is much more safer. Lower the suction, it is much more safer. Higher the suction, it tends to pull the retina into your cutter. So these are the components which you have to be aware of. Again, showing a small video of how the higher cutting produces lesser traction on the vitreous. And also, the lower the bore of the, smaller the bore of the cutter. When you switch from 20 gauge to 23, 25, and finally 27, they also have some of the 30 gauge which are used in some places, but mostly we prefer 23, 25, and 27. This is called port-based flow limitation. And as you can see, the larger bore tends to suck more vitreous, thereby causing more traction on the retina. The smaller bore tends to suck and cut less vitreous, thereby it is much more safer. This is called the sphere of influence. The sphere of influence is much smaller in smaller port size cutters, thereby increasing the safety of the cutting mechanism. So the risk of injuring the retina within the eye is much more lesser. This is called port-based flow limitation. This is why we prefer smaller gauge vitrectomy systems. So this is the evolution of the cutter size. The initial 17 gauge cutter was very big. Then came the 20 gauge cutters, 3-port vitrectomy system, and later on 25 gauge was introduced by Fuji and Lijuan, and then Eckhart introduced the 23 later on, and then now we have the 27, which was introduced by Oshima. So as the cutter becomes smaller and smaller, the suction at the tip of the cutter is lesser and also more focused. This is called the smaller sphere of influence and port-based flow limitation, which enhances the safety of the cutter. So this is why we prefer smaller gauge cutters compared to the older generation, which are very large and large bore cutters. So cutting speed I was talking about, initially all the cutters were spring-based. So the cutter has to move forwards and by pneumatic force, and the backward motion is by the spring action. But because of this, the limitation of the spring, the cutting speed could not be introduced beyond a certain level. So then now companies have started making dual pneumatic cutters, where the both the forward movements and the backward movements by pneumatic force. There we have a small valve which directs the air both forwards and backwards. So when you have a dual pneumatic cutters, the speed of the cutter can be much more faster, and you can enhance the speed much more compared to the spring-based cutters. So when you have a dual pneumatic cutters, then we have what we call as a duty cycle. So we can alter the time in which a cutter is open or closed. This is called open bias cutter and closed bias cutting. This is called a shave mode or a core mode in colloquially, but it is open bias and closed bias. In closed bias cutting, the speed of removal of the vitreous is much lesser, but the safety is much more. The accidental risk of injury to the retina is much lesser. When you have open bias, it is the speed of vitreous removal is much more, whereas the safety is lesser. So for doing the core vitrectomy, we prefer the open bias. When you are very close to the retina, doing close shaving, we prefer the close bias. And this is one very important step which enhanced the safety as well as the efficiency of the cutters. Initially, the cutter mouth was very away from the tip of the cutter. So thereby, we could not be able to reach very close to the retina when you are cutting. So now we have the newer port optimized cutters where the tip is 50% closer to the old generation cutters. So thereby, this enables the surgeon to use the cutter for multitasking. So the use of forceps and scissors can be minimized to a lesser level. So the cutter can serve the function of both the forceps with suction, and vertical, you can use it like a vertical scissors by cutting. So this is mainly enhanced by the optimization of the port, whereby the port is pushed towards the tip of the cutter. So we can cut the retina tissues which are very close to the retina without much of risk and in a much more efficient way. This is mainly because of the newer generation cutters which have an optimized port. So this was mainly achieved by spin, like initially it was a welded end, so now we have a spin closed end. So this is there are two different ways of placing the top lid over the cutter. So this is how they achieve this port optimization. So this, when the gauges became smaller and smaller, the need for putting sutures was lesser. So you previously in the 20 generation era, we had to put big sutures, and the eye was looking very angry in the first post-op day or for the first few weeks. But as in the newer generation micro-incision vitrectomy system, we don't use any sutures, and the eye is almost near normal in the very next day. So you can say this is a old generation 20 gauge surgery where you have to use either 60 vicryl or 80 vicryl to close all these wounds, and the eye looks really bad. And the newer MIV systems, without, you can use all these trocar cannula system, where the cannula is in situ and we can introduce all the instruments through this cannula system. And because they are very small, you do not need sutures at the end of the surgery. And it's like a phaco surgery, it's sutureless surgery. And it much more, the risk of early post-op astigmatism as well as the morbidity to the patient is much more reduced with the MIVS system. So just to remove the ports, and you do not suture the ports. You can just do a little bit of massaging for the sclera to come back to the old memory, and then you can leave it as it is. So regarding the visualization systems, how we visualize the fundus. So because of the extensive refraction happening at the lens and cornea, approximately around 60 diopters, you cannot see beyond the lens in a routine patient. We have to use some sort of lenses to view into the vitreous cavity and the retina. So this is the older generation of Lander's lens set, which you have to place it on the cornea by sewing on a ring. So this is a sew-on ring, which is first sutured to the limbus, around the limbus, and all the different lenses for different quadrants, we used to place it inside the ring and keep on rotating to see various clock hours. This was, even though it gave very good depth perception, it was a little bit cumbersome and the field was very less. So now we have wide field viewing systems. We have got a lot of choices now. Multiple companies have been using. So the Oculus Biome is there, and this is all non-contact systems. And then we have the just an image showing the wide-angle view in a non-contact viewing system from the Biome. And then we have the contact system also. This is also a cheaper payment versus Lander's PWL lens, which is a non-contact system. Apart from this, we have the like lenses similar to what we use for laser lenses, the contact lenses, which you have the Rodan. It's based on the Rodenstock model. It's a wide-angle contact lens, which you have a high positive lens, and a contact lens, which is encompassed in a single unit, which you use for routine lasers in the OPD. So similar sort of lenses are available for vitrectomy also. So these are all the contacts. You have both contact system and non-contact system. This is mainly to negate the severe high refraction which is happening at the level of the cornea and the lens, which approximately accounts for 60 diopters. So we use all these lenses to visualize into the. So we have two types of lenses: one the contact and the non-contact, and also we have the endoscopic vitrectomy for eyes with where the media is not viewed because of the scarred corneas. So we have introduced a small camera into the fiber optic camera into the eye using various tubes, and then this is a little bit expensive, not available in every all the hospitals. So few hospitals have it. So this is limited indications, which can be like retinal surgery for traumatic AD where the cornea is not compromised, view is compromised. And also some of the when in a white cornea, in a edematous cornea, to remove lens fragments. Endophthalmate is again where the view is very poor. And some of the pediatric vitrectomies to address the peripheral vitreous base areas where it's not easy to see with routine viewing systems. And finally, coming to the vitreous substitutes, again, Madan wanted to speak a little word on vitreous substitutes. We have 3: silicone oil, PFCL, and gases. So silicone oil, again, people may ask which silicone oil to use. We have the 1000, 5000, and also the heavy silicone oil, which comprises both a combo of PFCL and silicone oil. So irrespective of whatever silicone oil you use, the function is more or less same only. The big advantage, the only advantage with higher Centistokes oil is that the chance of migration into the anterior chamber is slightly lesser, but otherwise 1000, 5000, everything works more or less in the same way. Heavy silicon oil, whereas routine oil floats, heavy silicon oil tends to settle down towards gravity. So for people who have an inferior retinal break where they cannot push in properly, heavy silicon oil can be used. Heavy silicon oil is nothing but a combo of silicon oil with PFCL, a little bit more expensive. It is not authorized to market in India, so you have to sort of import it from outside. And then gases, which mainly serve for short-term tampering. So silicon is nothing but polydimethyl siloxane, and just showing a video how it's injected at the end of surgery. After filling the eye with the air, you just inject it, it just settles in the bottom because of gravity. And the most common indication of silicon oil is to do an internal tamponade of a retinal break. When you need a long-term tamponade of a retinal break, which can be either pre-existing or iatrogenic, which has happened during surgery. This is the most common indication. Occasionally, we use silicon oil for correcting permanent hypotony, or because of ciliary body atrophy, or sometimes to prevent recurrent vitreous hemorrhage. But 99% of the time when you use silicon oil, it's mainly to, if somebody asks what is the indication of silicon oil, it's mainly to do an internal tamponade of retinal breaks, which can either be pre-existing or can be iatrogenic during surgery it happens. So again, this is one of the common questions asked in postgraduate exams. So what are the factors which cause silicon oil emulsification? So the mainly low, you have a industrial grade and medical grade. When you use industrial grade, which is much more cheaper, it's a low purity oil, which again, the chance of emulsification. Emulsification is nothing but where the oil breaks up into multiple bubbles. So low purity, intraocular inflammation, intraocular blood. And when there is severe eye movements, the churning effect because of severe eye movements, either in nystagmus vision or people who are very highly mobile, runners, children. So these people are higher risk of developing emulsification. And when you have an incomplete fill where the oil is not totally filling the vitreous cavity, you have a small layer of aqueous inside the eye, which can again mix with the silicon oil, causing early emulsification. Gases, Ohm was the first person to use GAR as a tamponade. Now we have SF6 and C3F8, which is commonly used here. Again, when you have a short-term tamponade, especially for macro surgery or RD with superior retinal breaks in the superior quadrant, we need only short-term tamponade. We don't need oil which will warrant a second surgery to remove the oil. In these cases, you can use gases when you want short-term tamponade. SF6 is short-acting. It works only for 12 days and disappears within 20 days. And C3F8 a little bit longer acting. It can work for 38 days. It takes around 50 to 60 days to disappear from the eye. So these are the various gases which have been attempted for intraocular tamponade. When you want a short-term tamponade, very short-term tamponade, you can use SF6. You want a little bit more, you can use C3F8. If you want long-term tamponade, you go for silicon oil. And PFCL, it was first introduced as a blood substitute, and because it had a very high oxygen carrying capacity, people are trying to use it as an artificial lung for inspiration and expiration within the animal experiments have been tried for using as a, instead of air for deep sea divers, they have been trying to use this alternate for oxygen inhalation. But Stanley Chang was the person to identify the intraocular use, and he was the person who popularized all the various techniques. And we have the perfluoro N-octane, which is the commonest available in India. In outside countries, we have other compounds which are available, like perfluorodecalin, everything is there. And the main use is, again, it's a long answer question for postgraduates. So I'll just show this is how a PFCL is being injected in the eye to stabilize the retina in a retinal detachment surgery. And these are the various indications, like for stabilizing the retina in a retinal detachment surgery, to remove the subretinal fluid through anterior break during intraoperative. It's mainly used as an intraoperative adjunct. It's not meant for long-term tamponade. And for stabilizing the retina when you're doing vitreous base shaving and sometimes ILM peeling and recommendation retinal detachment. Also for peeling various proliferative retina with the membranes which are on the retina. And main indication is for addressing giant retinal tear. Without giant retinal tear, it's very difficult to, without PFCL, it's very difficult to manage giant retinal tear. In earlier days, people used to turn the patient upside down to do surgery, to put the air and to flatten the retina. But with PFCL, now it's very easy. Also sometimes to displace suprachoroidal fluid or blood, and also to remove intraocular lens and dropped lens fragments during cataract surgery. There's some of the indications for PFCL. I think I'll stop here, and the main medical conditions will be addressed by Mahesh as well as Chetan. Thank you. Thank you for your attention.
Superb, sir. Superb.
Wonderful.
Wonderful.
Excellent, Saravanan. I think you covered all the bases very, very well. I don't know. I feel I don't think there's going to be any doubts at all, unless Madan, do you have any points? Madan had already collated a few questions actually.
Yeah, this was based on.
Might get us. Madan, have all your questions been answered?
Yes, sir.
Okay. No,
We
because
have
that's
couple
how
of
we approach
questions
this.
from PGs. Couple of questions from PGs.
Yes.
We'll just put it across and we'll steer the discussion.
Yes.
Yeah.
Yes.
One of that question is, when we are doing an ILM or ERM peel, should we constantly change to a contact lens? That is the question. I think he's a young ophthalmologist. He's asking this question. Should it be viewed only with a contact?
Yes, when you're using a contact lens, as I told you, the depth perception is very, very good. So the tissues can be seen at a very greater depth. So it enhances the safety as well as the visualization of the ILM at the posterior pole. So that's why a lot of older generation surgeons prefer the contact lens because it gives super depth perception. But the newer generation, they are so much used to the non-contact system, so they don't usually change lenses. There also you have different type of lenses for peripheral different lens, for intermediate different lens, and for the macula, it's called a super macula lens, which also gives a very high magnification. But compared to a non-contact system, the contact lens gives you better depth perception, even though the field is smaller. So, but people are a little bit afraid to do on a very narrow field, looking through a tunnel. So a lot of the younger generation people prefer the non-contact system. But truly speaking, if you want to do a nice macular peeling, ILM or ERM peeling, I would prefer to use a contact lens because the super safety and super 3D perception. I think Mahesh also can add to this, whether we should really use a contact lens or we can do with non-contact also. ILM peeling.
Yeah, definitely. Like Dr. Saranan mentioned, using a contact lens gives a beautiful magnified view and pretty much safe. But then, like more out of laziness or we are used to it, we continue using the same lens which we used to do vitrectomy. That's also quite okay. It's not too bad, but like contact lens is preferred.
Yeah. Yes.
Another
question is like when I need to when I start a vitrectomy and that is the question. The question is like this: when I start a vitrectomy and the posterior capsule is very thick, I need to open up the posterior capsule a bit more. Should I change the setting? That is the question he's asking.
The capsule is not very fibrosed. You can go for open bias or core mode with a little bit low cutting. Not too low, but a little bit low cutting. If you are using 5,000, you can probably decrease to 2,500 or 3,000. Usually, normal capsules can be cut with 5,000 only. But sometimes if you are dealing with like in a pediatric cataract where the PC was very thick, it will not cut with cutter. So you have to make the initial incision with a sharp, either a needle or a paracentesis blade. And then you may have to use even scissors, intraocular scissors like the 23 gauge scissors to cut into multiple ribbons and then knead it with cutter. So cutter will not cut very stiff or very thick membranes. So you have to make the initial cut with some sharp instruments, usually a needle blade and also sometimes scissors.
Yeah.
In other words, if the capsule is pliable, it will mold into your cutter. When it's fibrosed and thick, it will not mold. So you need to make it into a shape which will enter your cutter port.
Enter your cutter. Correct. So he needs to lower his cut rate and do that. Okay.
Yeah.
One another question with a smiley. The question is like this. I think he's a phaco surgeon. He's asking, the phaco machine having vitrectomy, is anybody on research trying to have a single piece, like a coaxial vitreous cutter? Is there anything on research? That's what is being asked.
But it's already there, no?
It's already there.
Vitreous
out of use. It's not used.
Coaxial meaning where the infusion and the light, everything is incorporated.
But everything in a single piece, like a coaxial one. Now we have almost like a bimanual one, no?
When you have all the components in a single probe, the size of the probe is going to become very big.
Very big.
So the size of the sclerotomy opening will be very big. The very reason they made everything to separate is to decrease the size of the opening.
Yeah.
So it's not of
counterproductive.
There are still one or two phaco machines which come up with a combined infusion and cutting aspiration. Okay. AMO had one cutter like that, if I remember, until a few years back. I don't know whether it's available still. But I think there are other technical disadvantages also of having it other than the size. Because MPS can correct me if I'm wrong. I think if you infuse and cut in the same axis, there's more hydration and the efficiency goes down.
That's what
you need to hydrate in a different place and cut in a different place.
Correct.
That's why even if you're doing an anti-vitrectomy and bimanual, you're supposed to irrigate anteriorly and cut posteriorly.
Yeah,
that's what. I just have a couple of doubts. That's what Sriram. What I want to mention is when you have a PCR, So switch from a coaxial to a bimanual. The reason was that when you have a coaxial, that will hydrate the vitreous and enlarge the PC tap. Okay. So more and more vitreous will start coming into the anterior chamber. But if you have bimanual, that will tamper at the break. So that's why I think bimanual is always better. Saran, an amazing talk as usual. But I was trained. MPS also was in the thing. But we are all trained in the 20 gauge vitrectomy when he started, and we used to do that. But the 23 and the 25 and the 27 made a huge difference.
Exactly.
So I was wondering whether now we are because the port is very closer, and you can actually go very close to the retina, shave the retina with more safety factor, much better than before. Wondering whether you use the cutter for everything. You don't use the scissors at all, and just use the cutter for even removing the membranes there on the retina. So
it's not like we cannot do away with all these things. It has the scissors and the forceps you have to use in more tougher cases, but simpler cases without anything we can do. So the need for picking up the scissors and forceps has decreased in the MIVC era. That is true, but you cannot say we can totally do away. That is not possible actually.
Yeah.
Thank you.
And one final question, Saravanan. You didn't touch upon this area, but the question is this: how to avoid a dry tap when I am trying to take a vitreous tap and inject in an end of case? How to avoid a dry tap? That is what he's asking.
So when the vitreous is like this, mainly is talking about when you're taking a vitreous tap in endophthalmitis case, where when a young patient where the vitreous is gel form, as I told you, in the plain suction, it is not possible to remove the vitreous in every single case. The very reason we have a cutting mechanism is to cut this thing. But what we can do when you have a dry tap is most of the vitrectomy, most of the phaco machines have their own vitrectomy systems. So you can make a 3.5 millimeter small entry with a paracentrist blade and then introduce a cutter into the vitreous cavity and sort of a dry vitrectomy without any infusion. Just do a plain cutting. That will give you a proper sample. Instead of allowing the machine to suck in, you can connect a small syringe to the suction port and ask your nurse to suck it so that you can get a sample. In case a needle is not able to achieve a proper tap, that means the vitreous is very gel form. Pulling more suction is going to cause traction and possibly retinal tear and RD. So you can make a separate small sclerotomy using a sharp blade and then use your cutter which comes with a phaco machine to aspirate a small volume of vitreous for sample.
Yes. Done, Sriram. The questions from PG.
One thing because since you raised the topic, Rajshekar, many people think that in the endophthalmitis you can just put a needle. You can like they're putting a needle into the anterior chamber and taking an AC tap, put a needle into the vitreous and taking that sample with a 26 gauge or a whatever needle, 24 gauge needle, whatever it is. But I think it's not. What is the take-home message you want to give them? Because many people do that, and instead of cutting the vitreous, because unless you cut the vitreous, you will not be able to get the biopsy. Yes. Yeah. Saravanan, what's your
vitreous best removed only with a cutter, not with a needle. That's a take-home message.
We are speaking for a general ophthalmology crowd, no? So we'll have to give a take-home message. What is the best optimal thing?
Exactly. That's what Saravanan ended by saying. If you're getting a dry tap, don't keep trying. Which means if the vitreous is very solid, you're going to cause more damage.
Yeah. If you have a chance and resource, you can
best not do it. If you do it, if you don't get it on the first attempt, stop.
Correct. And inject and get it. Yeah, we can go to the next talk, Sriram.
Thank you, Saravanan. Thank you so much.
Very nice, Saravanan.
Thank you. Thanks.
The next talk will be by Dr. Makesh Shanmugam. Again, needs no introduction. Everybody's teacher. I fondly call him the Ethan Hunt of VR surgery. I'm not sure how many people know Ethan Hunt, the protagonist of Mission Impossible. So there is one dialogue where Anthony Hopkins says, like, this is not a difficult thing. This is Mission Impossible and only you can do it. So whenever I have Mission Impossible, I send it to MPS, sir. So, and he always in every movie, he always achieves the Mission Impossible. An authority in ocular oncology. And I will really love to listen to him talk about basics of retinal detachment, something which he taught all of us maybe a decade or two earlier. We really love to listen to your talk, sir. Over to you, sir.
Thanks, Dr. Sriram, for the kind introduction. I really don't know if I am eaten hunt or what. I try to do whatever I can. So let's get on with the presentation. So let me just share the slides.
Please share a screen.
Yeah, you can see now.
We're not seeing the screen.
Not able to see.
Okay.
You're seeing only your camera video.
Okay.
Of
Sir,
course,
may I
Mahesh
help?
is one person who can talk without slides also.
Sterling, sir, I know.
Whatever. Now it should be able to see.
Yeah.
Okay, visible.
Okay, sure. Thanks once again, Tnoa, Dr. Mohan, and Sadhu Gopals, and Dr. Abhishek for having me this evening. So we'll be speaking about retinal detachment. So the title says management, but as we go along, we'll be talking about the evaluation also. So let's start with the treatment principle and retinal detachment. The basic principles are these two. So this is what people will ask in the exams as well. So it is to identify and close all the retinal breaks. And in addition, to relieve the vitreoretinal traction. Because if you don't relieve the vitreoretinal traction, just closing the breaks doesn't help. So how do we identify all the breaks? So if we can look at where the breaks are formed, most often it's the superior temporal quadrant. So in any retinal detachment, look in the superior temporal quadrant, and there's a more than 3/4 chance that we'll be able to find a break here. Followed by the superior nasal and the inferior temporal quadrants, and the inferior nasal is where the breaks are the least. And what we need to identify is more than 50% of the eyes will have more than one break. So we should not be happy just to get one break. We should try to look for more breaks. That assures the success of the surgery. So link of roots, all of us are familiar with. So what does it help? It helps us identify the primary break. So there can be more than one break. There can be a lattice somewhere else with a break. But the break which caused the detachment is what the link of roots help us identify. But it doesn't mean that you close only the primary break. We have to close the other breaks also. That's why it's essential to identify all the breaks. So to simplify the link of roots, if you find the area of the detachment to be equal on both sides, so either superior or inferior, then the break is somewhere close to the midline. So it's either at 12 o'clock or 6 o'clock. So if it's a superior detachment and you find the area of the detachment, that is on either side of the disc, it's the same, then we find that the break is likely to be at 12 o'clock. And similarly, if it is coming from inferior detachment, both sides of the same level, then the break is likely to be at 6 o'clock. The other common thing is whichever side the detachment is more, the break is likely to be on that side. So if it's a superior detachment, we find that this side, the detachment is more, then the break is likely to be on that quadrant. Similarly, an inferior detachment, here I wouldn't say that the elevation is more or what, we just remember it as that side the detachment is more. So this side the detachment is more, the break is likely to be on that side. And sometimes you can find a trough, a small trough in the periphery connecting to a break. So in which case it can be a little bit confusing. The detachment can be equal on both sides, but we need to identify this trough. And in case of a total retinal detachment, most often we will find the break to be in the superior quadrant, 1 o'clock or on either side of the 12 o'clock meridian. So once we identify the break, the second thing is to close the break and relieve the traction. So there are 2 or 3 ways of how to close the break. So we can either push the retina towards the RP or push the eye wall towards the break or break. That is like we push this sclera and the RP towards the break, or push the retina towards the RP and the underlying choroid. So if you were to push the break towards the eye wall, we can either use gas or oil. That is, in the vitreous cavity, we inject something which pushes the retina towards the RP. And subsequently, what we have to do is once we close the break, this is not a permanent closure because this is just oppositional closure. So we need to close this permanently. How do we close it permanently? Is with retinopexy. What does retinopexy do is to create a sterile inflammation, and this creates a scar around the break. So there is a chorioretinal scar which walls off the break from the rest of the retina, so that the fluid doesn't go through the break and cause the retinal detachment again. So this retinopexy most commonly is being done with cryo as well as laser, but other techniques we look at as we go along the presentation. Coming on to the surgical techniques, what we use to repair a regmented retinal detachment are the pneumatic retinopexy, scleral buckling, and vitrectomy. Coming on to pneumatic retinopexy, it was started off as an office procedure, though most of the time you will see us doing it in the surgical theater for the sterility issues. So, but it can be done as in the office as well. So here in pneumatic retinopexy, we inject an expansile gas, that is 100% pure gas. In contrast to what we do in vitrectomy, we inject the non-expansile mixture. Here we inject an expansile gas, which is 100% pure gas. And when we talk about pneumatic retinopexy, there are two terms we need to remember. One is the surface tension and buoyancy. Surface tension is the one which makes the gas form a bubble. So this bubble, which has the surface tension, will close the break physically.
Okay, so
Thereby the vitreous cavity is cut off from the subretinal space, so the fluid doesn't enter anymore. Second is the gas bubble floats, isn't it? So that's the buoyancy. So it pushes the retina towards the RP as well. So these two things is what a pneumatic retinopexy achieves. Once the retina attaches, we can do a laser indirect ophthalmoscope aided laser. Otherwise, we can do a cryo and inject a gas bubble so that both can be done at the same sitting. That is, with the retinopexy as well as the injection of the gas can be done at the same sitting. So Dr. Saravanan has gone through the gas dynamics, and the technique is to usually use a 30 gauge or a 26 gauge needle, go through the pars plana, enter into the midvitreous cavity, then withdraw the needle close to the sclera and inject the gas bubble as a single bubble. So if once we inject this as a single bubble, then the risk of the gas, multiple small fragments of gas going into subretinal space or not achieving the aim of the surgery, that is to close the break, do not happen. So the volume of gas which is injected is about 0.5 cc of SF6 and 0.3 cc of C3F8. C3F8, of course, remains in the eye longer, so which can be inconveniencing to the patient as well. But the small volume makes it comfortable for patients who may have glaucoma or where you don't want to do a paracentesis, you can inject a smaller volume of C3F8. So what are the indications for pneumatic retinopexy? We are once again familiar. Any break in the upper 8 clock hours. So why upper 8 clock hours is like once we inject a gas bubble, the patient has to maintain a position so that the gas bubble goes and closes the break. So either we ask the patient to maintain a right lateral position or left lateral position. So once that position is maintained until here, the gas bubble can be pushed by asking the patient to maintain a particular position to make the gas bubble go and close the break. That is the reason the upper 8 clock hours is the usual indication for a pneumatic retinopexy. And the break should not be either a single break or should not be more than 1 clock hour, because the gas bubble injected is so small, it'll tamper out only 1 clock hour of the retina. So these are the cases which we select for pneumatic retinopexy. There should be no PVR and preferably no inferior fundus lesions, because if there is a lattice here, this can pull on the vitreous. So when it pulls on the vitreous, this lattice, there can be a retinal break in the lattice. So preferably no inferior fundus lesions. And the patient should be able to maintain a particular position. So whatever position we ask them to do. So the break is here. The gas bubble, actually, when we inject, doesn't go there, isn't it? It goes to 12 o'clock. So the patient's head should be tilted in such a way the gas bubble comes over the break. So once we inject a gas bubble, so we put an arrow on the patch and in the direction of the break, and ask the patient to maintain a position so that the arrow is always pointing towards the ceiling. So the patient should tilt the head this way or that way, depending on where the break is, so that the arrow is pointing towards the ceiling. So if the break is in the superior temporal quadrant, we put the patch with the arrow like this, and then ask the patient to tilt like this so that the arrow is facing up, so the gas bubble goes and tampers the break. The success rate with pneumatic retinopexy is around 80% with a single procedure and 98% with multiple procedure. The complications are if the patient has a macula on detachment and we inject the gas bubble, it can go and push the fluid towards the macula and cause a macula off detachment. So whenever we have a macula on detachment and we are doing a pneumatic retinopexy, we don't ask the patient to maintain a position right away, but we ask the patient to maintain a prone position. And every hour, every 10 minutes, then we tilt the head by 10 degrees so that the fluid which is towards the macula is pushed away from the macula and the fluid comes out into the vitreous cavity through the break, so that the fluid which is in the subretinal space doesn't go towards the macula and cause a macular detachment. Subretinal gas, if it is multiple bubbles, it can cause subretinal gas, but nothing needs to be done, it goes away. And any invasive procedure, you can have an endophthalmitis. Rarely macular hole can happen because of pneumatic retinopexy. PVR, because if you do a lot of cryo and the RP is liberated into the vitreous cavity, it can cause PVR. And the vitreous traction, because the gas bubble is pulling on the vitreous jelly inside, it can cause neuroretinal breaks as well. Now moving on to scleral buckling. Scleral buckling, the aim is to relieve traction, and it may or may not cause break. So we should not go with the concept that all the time the scleral buckling means that like the brake should be on the buckle and the retina should be on the buckle. It need not be. It can be, all we have to do is to relieve this vitreous traction, and that itself can allow the flap to close back, or the formed gel, particularly in young patients, the formed vitreous gel will close the brake from inside once we push the sclera as well as the RP towards the vitreous cavity. The traction is relieved and the formed gel closes the brake. So even the brake may be detached on the buckle, but still it will attach. The aim is to relieve the vitreous traction. In addition, the brake may or may not be closed. Most often we use an explant, that is, we put the buckle on the sclera and take sutures. Earlier we used to do implant, where we used to make a partial thickness scleral flap and then put the buckle there and then suture it. Why we used to use implants is that time one of the retinopexy techniques which we used was diathermy. So diathermy can be done only in the scleral bed, not in a full thickness sclera, because it causes contraction of the sclera and the intractor pressure can go up. So we have to create a partial thickness scleral flap, do diathermy, put the buckle and take sutures. But now that cryo and laser are there, we don't use this implant anymore. So what are the indications for scleral buckling? Any patient with retinal detachment we see, we look at where the brake is. Second thing is if the patient has PVR or not. If the patient has PVR more than one quadrant, that is what we call as more than C1 fixed fold, then these patients are not a good candidates for scleral buckling. Third one is like if the patient, these brakes are indentable. So when we examine the patient in the outpatient, you put a scleral indenter and see if that brake can be indented. So if it is indented, then these patients can be taken up for scleral buckling. Brakes which are so posterior that we cannot indent them, preferable to take them for vitrectomy. And again, there should be no vitreous hemorrhage or choroidal detachment, because vitreous hemorrhage will obscure your view in seeing some of the brakes, and we may miss brakes. So it's not a good idea. In choroidal detachment, earlier we used to do patients with choroidal detachment and retinal detachment scleral buckling. But subsequent studies have shown that like if you do vitrectomy in these patients, the chance of anatomical success are much better. So we stopped doing scleral buckling for patients with the retinal detachment and associated choroidal detachment. And scleral buckling is particularly preferred in retinal detachment young patients because they have young formed vitreous, and the vitrectomy can be difficult in the sense like induction of PVD and relieving all the traction can be difficult. So if there's no PVR, best is to do a scleral buckling in young patients, and it works quite well. In addition, these people are myopes, so you may have an anisometropy induced because of the vitrectomy, and then they develop a cataract, and then you work cataract surgery. There can be an anisometropy. So it's preferable to do scleral buckling wherever possible in young patients. And subretinal glyotic bands are technically a little challenging to remove with vitrectomy. And so if the subretinal glyotic band is elsewhere away from the macula, then once again, they do very well with scleral buckling. And retinal detachment associated with lattices. So in a lattice, the vitreous is attached all around, and it's attached to the vitreous space as well. So to remove this vitreous safely without creating a break and completely is very difficult. So once again, these patients do pretty much well with scleral buckling surgery. Now let's look at the steps of the surgery. So you open the conjunctiva at the limbus. Earlier, we used to open away from the limbus in aphakic and pseudophakic patients. So here, 360 degrees, and we make relaxing incisions, usually in the superior temporal quadrant and inferior nasal quadrant. And next is to open up the quadrants. That is like we go around with a closed Steven scissors, curved scissors, go in between the muscles and open the blades and come out. So this slices the attachments between the conjunctiva and the Tnoa capsule. Next is like muscle tagging. Usually all the muscles are tagged if you're going to place an encircling band. Otherwise, at least the 3 muscles in the area where we're going to place a segmented muscle are tagged. And whenever we tag the muscle, we should keep our ear on the monitor, particularly in patients under general anesthesia, because they can develop an oculocardiac reflex. And it's most common with the medial rectus. Next step is to inspect the sclera. So this is to see if there's any areas of radial dehiscence which can rupture, or when we place the suture, it can go through the eye, and also abnormal vertex veins as well. Next step is, once this is done, we put on the indirect ophthalmoscope or use a chandelier to localize the breaks. So what is localization is, we are mapping the retinal breaks on the sclera, so that like with the scleral buckle, the silicone implant which you put comes over this piece of with the retinal break as such. So what do we localize? In a horseshoe tear, we use what we call a 3-point localization. So the apex of the tear and the 2 base, the horns of the tear. So these 3 are localized on the sclera. In a lattice degeneration, what we do is to the posterior most and the lateral most. So here and here, these are the 2 localization marks which we do. And then if it's an atrophic hole, a single point localization, which is usually the posterior part, is what is localized. So we place these marks on the sclera. So we don't go around localizing everything, but for instance, a patient has this one like lattices with the horseshoe tear. The posterior most part is again localized, and the lateral most part where we want the buckle to come from is what is localized. So to localize, what we do is to start depressing from the aura. You can see the forceps is used to localize, and there's a break here. So you go to the posterior most part and then press on the sclera to leave a temporary mark, and then make it permanent with a forceps. With a cautery. So you place the cautery mark or a diathermy or a dye to mark this, because once the temporary mark is removed, then it vanishes. So you have to make it permanent. So when we place the buckle, we need to know which are the areas we have localized. So make that mark permanent with cautery, diathermy or dye. And once this cautery mark is placed, we usually place a cotton bud and then depress and once again see if we have localized precisely, because this step of localization is the most important step of scleral buckling surgery. If this goes wrong, then everything else subsequently will go wrong. In bullous retinal detachment, there can be a parallax and there can be a false posterior localization. So in those steps, like in those situations, then we start do some like maneuvers, like start indenting from anteriorly in the meridian of the break and go posteriorly. And there are some indirect clues like pigmentation in the choroid and the retinal pigment epithelium where the lattice was. That can also give us a clue as to actually the break is much anterior than posterior. And if the retinal attachment is so bullous that we are not able to localize precisely, then you can drain the fluid. So here you can drain the fluid, reattach the retina, and then localize. So once we drain, we can inject air or we can inject fluid to reattach the retina and then localize once again. So this is what we call as the drainage air cryo explant technique or the DACE technique. But most of us, practically, we don't inject air, because once we inject air into the vitreous cavity, it becomes difficult to see the fundus clearly. So we would inject fluid and then go ahead and with the further steps of the surgery. So once the localization is done, then we have to create this sterile inflammation, that is the retinopexy. So either we do cryotherapy. Photocoagulation is difficult because for photocoagulation to work, the retina and the retinal pigment epithelium should be in opposition, because the laser energy is absorbed by the retinal pigment epithelium, then transferred to the retina. But if you have a diopexy probe, yes, we can transclerally deliver the laser energy as well. Most of us but do not have it. But once we reattach the retina, we can do a laser indirect ophthalmoscope aided laser as well. Diathermy, as I mentioned earlier, is not no longer used. We used to use that in the days of implant surgery. So here you can see the cryo being done. So usually you don't treat the bare RP under the break, because that RP is the one which comes to the vitreous cavity, can cause PVR. So place the burns all around, touching each other. And if it's preferable to extend to the aura as if possible, because if you don't extend to the aura, there can be leakage of fluid anteriorly, which can again cause recurrence of the detachment. So treat all around and extend it to the aura. Once the retinopexy is done, next is the question of selecting the buckle. So wherever possible, we start buckling from the ora towards the posteriormost part of the break. So how do we select the buckle is, the buckle should be adequate to cover the break completely. So if the break is close to the ora, you start from the ora, and posterior is the most important. So we select a buckle which covers 3 millimeters of normal retina posterior to the break, and on either side about 2 millimeters. So this should be the ideal size of the break, the size of the buckle which is selected to close a break. In case the break is too posterior from the ora serrata, then once again, like you clear 3 millimeters anteriorly as well as 3 millimeters posteriorly. So you should select a break which will cover 3 millimeters anteriorly as well as posterior to the break. And when we place the suture for placing the buckle, in addition to these measurements which we have made, we have to add another 2 millimeters. So for instance, the break is about 5 millimeters from the ora serrata, the buckle should be at least 8 millimeters. So 5 plus posterior 3, 8 millimeters. The suture spacing should be 10 millimeters apart. So that will be adequate enough to achieve a good buckle effect. So here we see a technique of taking the suture.
1 hour.
So here we are taking a radial suture, then a circumferential bite, which is taken. So this can be a radial bite or it can be a circumferential bite as well. So this is how we take the suture when we do a scleral buckling. Here again, I'm taking a radial suture, but this can be a circumferential bite as well. So suture basics is it's about half thickness of the sclera, and the travel of the needle tip is visualized through the sclera all along. And posteriorly, the bite is broad because the anterior part of the muscle ring is narrower part. So that part of the anterior bite is narrower, posterior is a broad suture. And another basics is, if you're going to buckle a quadrant, at least 2 sutures should be in each quadrant. And the posterior bites, as I mentioned, are to be closely placed to the adjacent suture to achieve a good buckle effect. And we can place just a radial buckle or a segmented buckle as well. If you're placing a radial buckle, the sutures are not circumferentially oriented, but they are actually radially oriented. So here we see the suture being taken, partial thickness, that's about half thickness scleral bite. And here we do the reverse direction. And you can see the buckle is placed there. So this is just a segmented buckle without an encerclage, which can also be done. So subretinal fluid drainage is not all the time necessary in a scleral buckling surgery. If there is a pullous retinal detachment, if the patient has got glaucoma, if it's a long-standing retinal detachment, inferior retinal detachment with horseshoe tear, then you would prefer to drain. So when there is no need to drain, if it's a lattice-associated detachment with an atrophic break, the vitreous gel will close the break, so there's no need to drain. Young patients have good RPE, so the RPE pump will pump out the fluid. Superior retinal detachment, you can tamponade from inside with air as well, along with the buckle. And if there is a limited area for drainage, then there is no need to drain as well. So where do you drain? We drain in the area of maximum fluid, preferably on either side of the muscles, preferably the horizontal muscles, and preferably the posterior part of the thing. So here is one technique of drainage where I use a 26 gauge needle, a tangential entry and press, and then you can drain. This is the classic usual technique of cut down. So you cut down, expose a knuckle of the choroid, and you can either enter with the needle, or here I'm using the laser to do the choroidotomy. Laser coagulates the blood vessels and also achieves a safe drainage because it doesn't. There's no risk of damaging the retina when we enter with the needle. The other one is the diathermy, which I showed you before. And coming on to complications of scleral buckling, intraoperatively, it can be globe rupture if there is radial dehiscences or thinning behind the muscle, and when we hook itself, we can rupture the muscle. Muscle can be lost when we drag the muscles and the assistant pulls the muscle to expose the sclera. There can be choroidal bleed when we do a choroidotomy for subretinal drainage, subretinal fluid drainage, subretinal blood, vitreous and retinal incarceration. Most of these complications occur when we do the subretinal fluid drainage. Post-operative, there can be extrusion of the buckle infection, anti-segment infection, and strabismus. Scleral buckling is a wonderful surgery. gives us very good anatomical results of around 90 to 95% reattachment of the retina. And 50% of the eyes with successfully reattached retina obtain a visual acuity of 20/50 or better. And in macula on cases, 10% would still have some loss of vision, though we reattach the retina due to different causes. Now, moving on to vitrectomy. So if there is retinal detachment with PVR more than C1, that is fixed fold in more than one quadrant, you have to do a vitrectomy with peeling of all the membranes. But even in primary retinal detachment without PVR, there are certain indications where you would want to go ahead with vitrectomy. So in the giant retinal tear, even though there is no PVR, we go ahead doing a vitrectomy. Similarly, coloboma choroid retinal detachments. As I mentioned, retinal detachment, choroidal detachment does better with vitrectomy rather than scleral buckling. Retinal detachment with vitreous hemorrhage because we can see the breaks. Macular hole or posterior retinal breaks, even though there is no PVR, we go ahead with the vitrectomy for reattachment of the retina. RD with retinoschisis and RD in pseudophakia. So RD in pseudophakia, even if there is no PVR, we prefer a vitrectomy because there can be tiny breaks which can be missed. So it's preferable to do vitrectomy in a primary regular retinal detachment with no PVR in pseudophakic patients. So the steps of the surgery, all of us are familiar with: 3-port pars-plana vitrectomy, 4 vitrectomy, and in case there is no PVD, then you induce the PVD and complete the vitrectomy with base dissection, that is vitreous base dissection. Then if there are PVR membranes, we peel the membranes, and in case the peeling of the membranes is not adequate to relieve the traction, then we do a retinectomy to relieve the traction. Then reattach the retina with the fluid gas exchange, or in select situations, perfluorocarbon liquid. Then do retinopexy, and then you do tamponade. So here we see some steps of the surgery. You can see multiple breaks and multiple quadrants, and some of the breaks are anterior, some of the breaks are posterior. These are going to be difficult to buckle because it will be an extensive buckle. So here we have induced a posterior vitreous detachment. You can see that vitreous which is pulling on the anterior flap of the tear. So that is being relieved by removing the anterior flap of the tear. So, and once all this vitreous from the posterior to anterior is relieved, the vitreous base is debulked by doing a peripheral vitrectomy. Then here we have used a bubble of perfluorocarbon liquid to keep the posterior retina in place when we are doing the vitreous base dissection. So that's the vitreous base dissection which is being performed. We may not be able to completely remove the vitreous, but we debulk it as much as possible. So once that is done, then we do a fluid air exchange. So this is the fluid air exchange. You keep the flute at the break and the air is injected, and that pushes the subretinal fluid out of the break into the flute and out of the eye. So once the retina reattaches, then we do retinopexy with laser photocoagulation here and use tamponade. So these are the basic steps of a vitrectomy for recommended retinal detachment. So this shows the vitreous base dissection. This patient is a phakic patient. So we depress and debulk the vitreous close to the vitreous base. So leaving this vitreous can proliferate, can result in a recurrent detachment. So we have to debulk the vitreous as much as possible. You can see the vitreous base has some membrane formation. So we need to carefully peel the membranes and remove the vitreous all over there. So here let's see membrane peeling. So this patient has RD with PVR. You can see the PVR here. So you can see the fixed folds here, and this has a large break here. So we have done the core vitrectomy, then debulk the peripheral vitreous as much as possible, then go between these fixed folds, and we have these PVR membranes which are grasped and peeled. So it's very important to peel all the membranes and make the retina mobile. And the tamponade is not a substitute for good membrane peeling. So putting in oil is not going to reattach the retina. We have to peel all the membranes. Once the retina is freely mobile, then we have done the fluid air exchange to reattach the retina. The retina which is completely crumpled, you can see how it has opened up quite well after membrane peeling. Sometimes subretinal gliotic bands can be there, which will prevent the retina from reattaching. As I mentioned, subretinal bands which are going across the macula have to be removed. Here, this patient has a napkin ring. So it's around the disc. which is keeping the posterior retina closed. So here we are entering the subretinal space with the forceps and removing the membranes. You can see this, the circumferential subretinal gliotic bands. So you can access most of the subretinal bands with just a properly placed retinotomy. So that's a large subretinal band. You can see the posterior pole is closed because of a napkin ring. That also would have to be removed. And once we remove this, the vitreous, the vitreous base dissection is also performed. So I placed another retinotomy temporarily as well to remove the band. And now we are doing a fluid air exchange. The fluid is at the fluid, at the break. And you can see the retina has opened up nicely, and we have used silicone oil as a tamponade. So as I mentioned, some situations you may have to do a relaxing retinectomy. Here you can see that the pre-retinal membranes are removed. And we look for any subretinal membranes that is also has to be removed. All the membranes have to be removed before we think of doing a retinectomy. So despite removing all the membranes, this retina is a bit stiff, and that could be because of intrinsic contraction. And when we are not able to relieve that traction, then we resort to a retinectomy. So here, once again, after putting a bubble of perfluorocarbon posteriorly, I'm still trying to peel all the membranes, but despite which you can see this radial contracted retina, which is not going to reattach. So we are doing the retinectomy. Retinectomy is usually done at the where the vitreous is. We are not able to peel it any further. That will usually be at the vitreous base. So that at that age we do the retinectomy. So here this patient underwent a 360-degree relaxing retinectomy, and reattach the retina with perfluorocarbon liquid and use tamponade. So tamponading agents here in a vitrectomy, we use non-expansile mixture. So C3F8 14% or SF6 20% is what is usually used. Silicone oil, we can use 1000 to 5000 centistroke. When we want a longer tamponade and we think that we are not going to remove the oil in 3 months, we use 5000 centistroke oil. Heavy silicone oil is used for patients who are unable to maintain position or inferior breaks, because this kind of settles down like a perfluorocarbon liquid. In contrast, silicone oil floats. So the lower part of the retina is not tamponaded with silicone oil appropriately. So when do we use gas or oil? Gas is used when there is no PVR and good traction relief is achieved. Usually, we don't use gas in eyes which have had to undergo a relaxing retinectomy. And patients should be able to maintain position better, preferably superior or fewer breaks. And the other eye should be functional, because once we put gas, the patient doesn't see in this eye until the gas bubble is like absorbed sufficiently so that the macula is free of the gas. So it may take about a couple of weeks. And primary surgery, that's the first surgery when we're doing a vitrectomy, usually I would use gas. Oil, when we require a longer tamponade, and whenever we do a relaxing retinectomy, oil is what is preferred. And patient has to maintain position even with oil, but not as strictly as with gas. And multiple breaks inferior, we prefer using heavy oil. And if the other eye is blind, then prefer oil, because the patient can be rehabilitated faster. And the revision surgeries, once again, we use oil. Complications of vitrectomy, intraoperatively, can have hemorrhage, either from the break or from the subretinal space, or hemorrhagic choroidal detachment, but though they are uncommon. But more common are iatrogenic retinal breaks, retinal confusion, or retinal detachment can happen. And lens injury can happen in fake patient if you're not careful. Postoperatively can have elevated intraocular pressure, cataract, endophthalmitis, refractive error, retinal detachment, and anterior highlight proliferation. So to summarize, retinal detachment management, pneumatic retinopexy is a simple procedure in select cases: superior retinal breaks, no PVR, single break, or breaks within 1 clock hour. Scleral buckling is what is preferred in young phakic patients, and vitrectomy is what is preferred in most retinal detachments which are complicated by PVR or with posterior breaks. Thank you very much for the kind attention.
Marvelous, sir. Superb, sir. A lot of questions have been typed in.
Thank you, sir. Thank you so much.
Really marvelous. I think it was a masterclass on buckle. No, nobody. I thought everybody has forgotten the buckles, but kindled. Mahesh has actually kindled all of us.
Yeah.
The dying art, sir.
Now, Mahesh, I have some questions for you.
Before that, Dr. Vijay Shanmugam is online.
Yeah, Vijay, okay, fine. Let him come.
Switch on his video and come online. Dr. Vijay?
Jai Shanmugam sir, good morning. Good evening.
Madan, if you have his number, can you give him a call? No, again, he's gone offline.
I'll call him. I'll call him.
Yeah, please. Thank you. Yes, sir. Please, sir. MR, sir.
Mahesh, I think it's really an amazing talk, and you have covered every aspect of buckle. Because in fact, I have done more buckles than vitrectomy during my VR fellowship. At that time when we were used to thing, and even now, if I want to demonstrate a buckle, I demonstrate buckles to my postgraduates to just to show them how to do a buckle. Buckle is an art, and as you rightly said. But I have a certain this thing. For example, when do you decide, okay, that this patient will require a circumferential buckle or a radial buckle? Number one. That's one thing. And second thing is the bullless RDs. I always used to admire my guru, mentor, Dr. SSB, Chief Dr. Badrinath. When you have bullless RDs, very difficult to localize the break. And also, he does the days technique. And I also used to do the days technique wherein I drain first and put in air. And of course, putting in air makes it a little more difficult to localize at that time because the view becomes a little hazy. So by putting in fluid, so you said you can put in fluid instead of air. So then we do the cryo and then the explant. It's called the days technique, which I'm sure everybody has done it. So we used to do that for bullless RDs. So what's your preferred technique for bullless RDs? And when do you decide whether circumferential or a radial buckle? Or because that's, I think, a very important thing to decide. Yeah.
Circumferential, any break which will fall to about 10 or 12 millimeters from the muzzle ring, we can like up to 10 millimeters we can manage with the circumferential buckle. Anything posterior, we prefer to do a vitrectomy nowadays. So radial buckle is not too many people do that. In select situations, I do a radial buckle even today. So anything posterior is when we do a radial buckle. So posterior breaks, single breaks, you would want to do a radial buckle. But anything anterior to the equator, you can manage with the circumferential buckle. Other indication for a radial buckle would be if it is a HST, which is fish mouthing. So if it's fish mouthing, then you would want to probably place a radial buckle so that like the buckle extends posteriorly and the fish mouthing can be prevented to some extent with that. And the second question was about the days technique. Yes, the days technique, as you very rightly said, Dr. Mohan, that like air will interfere with visualization once again because we have a lot more steps of surgery to be done, which we have not completed when we have drained and then localized. So I do inject fluid, but like the key is not to inject the fluid which is directed towards the break, because if it is directed towards the break, the fluid can go under the break and then again make the retina bullous. So inject in such a way that it doesn't go through the break, but in another area. And you don't want a completely flat retina, just about like sufficiently shallow that we are able to localize better. That's all we need. So I would usually inject fluid, not air. And sometimes I put an infusion cannula, 25 gauge infusion cannula, so that like the globe is formed when we drain. So there is no hypotony associated complications as well.
Fantastic. Very nice.
So I have two questions, sir. One, actually, you had made a passing mention. In my PG days, we used to get asked, when will you do a vitrectomy in an RD? So probably I should rephrase that question to, when would you not do a vitrectomy in an RD and only go for a buckle? You had made a passing mention of that in your talk, but to make it more explicit.
Yeah, I would prefer not doing vitrectomy in a young patient with more of subretinal proliferation, subretinal PVR, that is subretinal gliotic membranes, and patients with lattice degeneration associated breaks. So any fixed fold more than C1, that is like more than 1 quadrant involvement, then it won't work with the buckle. But up to 1 quadrant fixed fold, but the break is not close to the fixed fold elsewhere, we can get away with the buckle. And subretinal gliotic bands, once again, as I mentioned, if it is not close to the break, if you just close that, Sometimes the retina can get tented up in the periphery, but then it will over time will reattach. Younger patients, and once again, there are many reasons why you would not want to do a vitrectomy if they don't have a PVR. Because one is they may have vitreous, which is very adherent. It's going to be difficult to peel and achieve sufficient relief of vitreoretinal traction, particularly around the lattice degenerations. And also, as I mentioned, these patients are most often myopes, so they may have same degree of myopia in both the eyes. But one eye, you're going to do a vitrectomy, then make them anisometropic, and then like remove the tamponade, they will develop a cataract. Once again, remove the cataract and make this eye emmetropic. The managing the other eye becomes difficult. So, considering all these, younger patients, no PVR, SRGs, and 1 quadrant fixed folds, I would prefer a buckle.
And my next question, sir, the perennial question, in this day and age, when do you do an encerclage and a vitrectomy for RD?
Encerclage in a vitrectomy, if it is an inferior lattice or an inferior break or multiple lattices, all 360 degrees, then I would place an encerclage. My dictum is like this. So do the best you can so that you can go back home and sleep better, wondering whether the patient will have a redetachment. So if it means placing an encerclage, yes, place an encerclage. I don't place an encerclage if it's a superior HST or a superior breaks where it can be tamponaded easily with gas. So anything inferior, I would probably place an encerclage. Though whatever the studies may say that there is no difference, whether you place an encerclage or don't place an encerclage, the anatomical results are the same. As I mentioned, like for my own satisfaction, I would place an encerclage if at all there is anything inferior.
Thank you, sir. Thank you so much.
Sriram, couple of questions from the PG.
Yes, sir.
One question is, sir, MPS, sir. B-scan just before surgery by the surgeon. So what are the points a B-scan can tell the surgeon that will be useful on the day of surgery? That's what I think is great.
B-scan would be necessary in case we are not able to see the fundus. So if you're able to see the fundus, there's absolutely no need to do a B-scan.
No need.
If you're not able to do, there's no view of the fundus. If there's a associated vitreous hemorrhage, the B-scan may be able to tell us where the vitreous is attached, where the vitreous is detached. But if you're doing a vitrectomy, it really doesn't matter actually, because you're going to go inside and see where the vitreous is attached, where the vitreous is detached. So if at all, for us to enter the eye, it may be required. If there is a choroidal detachment and you want to enter the eye, and then you'll probably plan your sclerotomies in such a way that you want to drain the suprachoroidal fluid, then inject the fluid, reattach the retina, reattach the choroid, and then enter the eye. So in that situation, I would suggest probably a B-scan may be useful. So an RD with a CD, then the B-scan tells us, yes, there is a CD in the temporal quadrant. So you cannot just like that place a sclerotomy. So drain the choroidal detachment, inject the fluid, reattach the choroidal detachment, then place a sclerotomy. That in that situation, it's useful. But otherwise, any other situation, you can go inside and see for yourself.
Yeah, yes. And what all can be done by an endodiathermy? That is a question. Endodiathermy, how much MPS uses? Probably that's what they're asking.
Endodiathermy is used to mark the breaks, particularly in myopic patients, because once we do a fluid air exchange, that the break may not be visible. So for us to visualize the break, for us to do a retinopexy, once we do an air fluid exchange, then we mark the break with that. If there's a break, if there's a bleeder, then we cauterize it. That can also be done for endodiathermy. And when we do a relaxing retinectomy or a retinotomy, we once again use the endodiathermy to make sure that it's not going to bleed. And also there's no ooze from the cut end of the retina. So these are the situations when I would do an endodiathermy.
Yes, yes. Other points you have touched upon, sir. There are other questions, but you have touched upon. Sriram?
Yeah, I think, yes, somebody wants to say something.
No, I want to say.
Yes, sir.
Mahesh, what is the indication for vitrectomy? Do you still do vitrectomy buckles?
Yeah, that's what they did ask. I do a vitrectomy buckle. So usually inferior break, I would place an encerclage if there is an inferior lattice and inferior break. The buckle as such is rare. Vitrectomy plus scleral buckling where we put the solid silicone is a bit rare, unless there is very severe traction, which I may not be able to relieve. Young patient, I don't want to do a retinectomy. In that situation, I would put a vitrectomy buckle. That's rare.
Otherwise, just a belt buckle, 240.
Yes, belt buckle. Yes, 240.
Thank you, Mahesh. Sorry.
Thank you.
Thank you, sir. Thank you for such a wonderful talk. We'll move to the third and the last talk of the session by Dr. Chetan Rao, Senior Consultant Vitreoretinal Surgery at Shankar Nethralaya. I know Chetan more as a friend rather than a VR surgeon. So 2 things I can tell about him. He's a very rare combination of being a no-nonsense person and also being compassionate at the same time. It's a very rare combination, and I'm sure we're going to have a total no-nonsense on your face talk now. Chetan, over to you.
Thanks, Sriram. Yeah, I've known him from almost 20 years now. He's also an equally no-nonsense person. So I think
that's
we all
where we gel.
Yeah, birds of the same feather.
I'll prefer to say an all-nonsense person. But that will be in a private occasion.
Sriram is full nonsense guy.
So I have a little more specific. The talk is a little more specific than both Saranand and Mahesa, and it will be on proliferative retinopathy. And let me share my screen. So I'm going to talk about the indications, principles, and goal of surgery for proliferative retinal vascular disorder. And we're basically going to talk about diabetic retinopathy and proliferative diseases due to retinal vein occlusions, proliferative new vessel disease due to retinal vasculitis, which is what we actually encounter in our practice. So we know just a small brief about PDR, the pathophysiology and progression of PDR, proliferative diabetic retinopathy. When you have profound ischemia, it triggers new vessel disease. Now, when the new vessel disease develops, it's usually flat on the retinal surface. But then as it grows, and when it's not treated, it goes into the posterior hyaloid, which acts like a beautiful scaffold. And there starts the complications of proliferative diabetic retinopathy. So when this grows into the vitreous, into the hyaloid gel, it spreads on the undersurface of the hyaloid as well as into the hyaloid surface. And then it lays down matrix, extracellular matrix, undergoes fibrosis, and starts contracting. This remodeling causes a lot of destruction in the architecture of the retina and also leads to complications like vitreous hemorrhage. So here is an example of an extreme distortion by the proliferative retinopathy. This has gone untreated for long and it has undergone cicatricial changes. You see fibrosis, and it has caused so much obstruction that the retina is actually split and it is almost atrophic at the macula. Similarly, you have traction which slowly develops over a period of time. A patient comes to you with a new vessel disease. You do a lot of laser, and then this laser induces a little bit of regression of the vascular part of the proliferation and lays down fibrosis. This fibrosis contracts, it causes remodeling, and then stretches the retina, which is already ischemic, and creates holes and chytic cavities in the retina, distorting the architecture and, of course, affecting the vision. Then you have tractional retinal detachment. So when the fibrous tissue is very close to the disc and macula, it can contract and lead to a detachment of the retina. And when it detaches the macula, it causes loss of vision, and it is an indication for surgery. And lastly, when we have the contraction of the fibrous tissue, along with the hyaloid detachment as well, contraction of the posterior hyaloid, which is the connection from the vitreous base to the prolif in the center, that causes additional traction on the retina, creating breaks at the base of the proliferations, causing a rhegmatogenous component to the tractional component which is already there. This is called a combined retinal detachment. This is an example of a combined retinal detachment. You can actually see the retinal corrugations, which are very classical of a regmatogenous component, where when you see such a thing, it's quite obvious that there is definitely a break somewhere at the base of this proliferation. This is a case of this is an indication for early surgery, because a regmatogenous component to a tractional component versus the prognosis for vision even after a good surgery. So what are the investigations before surgery? We always prepare ourselves when we do a diabetic vitrectomy. It's important to know a very important thing is what is the condition of the posterior hyaloid. In other words, whether there is a posterior vitreous detachment or not. Ultrasound is still a very good investigation, which tells us about the relationship between the retina and the posterior hyaloid. So, and especially if you have vitreous hemorrhage and you cannot see the retina, it's very important to do an ultrasound. Helps you to plan the surgery, and you can prognosticate whether you will need a tamponade in this case, how long will the surgery take place. You can even tell the patient that there could be a lot more complications after a surgery. So as you see in the right-hand side, you see ultrasound. It could come in a variety of configurations. We have just a posterior hyaloid detaches, and there's a single attachment to a prolif, whether it is on the disc or somewhere else in the retina, and you have a tenting of the retina. It's a focal detachment of the retina. Or you can have a hyaloid which is causing multiple attachments at the posterior pole, especially between the arcades. Usually the vessels develop along the arcades, new vessels develop along the arcade, and they can pull the arcades and cause a detachment like this around the macula. And eventually, sometimes you have something called a tabletop detachment, where the hyaloid, the new vessel is grown along the macular surface and then gets detached in toto, causing a detachment of the macula itself. Also, we know the extent of retinal detachment. We know whether it is sometimes under the vitreous hemorrhage. We know whether it is RD, which is extending up to the periphery. We know very well that there could be a combined retinal detachment underlying the vitreous hemorrhage. Another very important investigation nowadays that we do, especially in case of clear media and good vision, we're sometimes always wondering whether the fovea is in its place or not, because there is a traction and there is subtle detachment of the hyaloid over the macula. And we don't know whether the fovea has been detached. Sometimes what we call as fovea threatening traction retinal detachment. So in this case, if you can see, the fovea at one edge is attached, but at the other end is detached. This is the traction which is caused by a hyaloid which is detached from the fovea, but still attached to the proliferation at the edge of the macula, and has caused a macular detachment. At this stage, the patient can still have good vision, but the quality of vision is poor. This is again an indication for early surgery. So what is the goal of surgery in any proliferative retinopathy? Clear the media. If you have vitreous hemorrhage, you have opacities, clear the media. Release all the posterior retina, the posterior retina from the anterior posterior traction, which is the posterior vitreous detachment, which is the connection between the posterior retina and the vitreous base. Third, release the macula and the disc from the epiretinal contraction by segmentation of the proliferative membrane, so that the macular detachment or the stretch or the chysis is relieved. Thirdly, adequate hemostasis. Most often, the failure of visual recovery is due to poor hemostasis, attention to detail during surgery, where every bleeder is cauterized, so that at the end of the surgery, we have a bloodless field. Also, if there is a retinal break during manipulations in the, very often we have membrane dissections which can lead to a retinal break, need to isolate the break and good photocoagulation around the break, and use tamponade to attach the retina. In addition, we have to do adequate laser ablation to the ischemic retina, to control the new vessel, which can still regrow even after removing it during the vitrectomy procedure, because this reduces the risk of the reproliferation, which also reduces the risk of rebleeding post-surgery. Many times, a month later, you can have a rebleed because of reproliferation. And also, when you have a reproliferation, you can have again epiretinal contraction and redetachment. So we already touched upon, Saravanan has already touched upon the surgical instrumentation. In the current era, we have high-speed cutters with great fluidics, and very less what you call trauma to the retina when we are doing a surgery close to the surface of the retina with a high-speed cutter. We can dissect membranes just with the cutter alone, and he's already mentioned about the port opening being very close to the end of the cutter, which allows us to take the cutter close to the retinal surface and dissect the membranes by lifting it and cutting it. There is still a role of intraocular scissors in surgery. There's still, and of course, wide-angle viewing system allows us to do the surgery at a faster speed and do a much more good dissection all the way up to the periphery. So we can visualize all the way up to the ora as well as the posterior pole using the wide-angle system and do a very good job of removing all the proliferations and the traction associated with it. In this era of high-speed cutters and good quality fluidics, which reduces the traction of the retina, there is still a role for intraocular scissors, where when we face certain situations during vitrectomy. So what are the surgical steps? After you make the sclerotomies, the first thing you do is you debulk the vitreous, clear the opacities. Next, release the posterior retina from the anterior posterior traction, which is you identify where the posterior vitreous is detached from the retina and enlarge that opening so that the retina, so that the vitreous is separated from the posterior proliferations from the peripheral vitreous space. So this is just a cartoon. This has been used a lot of time. It's courtesy one of our fellows. We debulk the vitreous, make the tissue more mobile, disconnect it from the vitreous base. Next is release the macula and disc from the epiretinal contraction by segmentation of the proliferative membrane. So now the contraction, the surface contraction of the retina, we cut and segment the membranes. The disc is separated from the macula and the macula is separated from the membranes, and then they're all removed with cutter dissection. This is a video where I would like to show you the steps that we follow during vitrectomies for diabetic retinopathy. So here you see this vitreous hemorrhage. You can faintly see the disc. Ultrasound has shown that there is definite hyaloid separation, but there is less separation in the nasal part. And this has previously been lasered, which is also a very useful tool. Laser preoperatively, if there is a view, helps in contracting the vitreous and creating a plane when the vitreous detaches. So here you can see there was an opening in the nasal. I'll just go back. There was an opening in the hyaloid, which is a nice area to start dissecting and removing the vitreous gel, the hyaloid. And here's an area where the vitreous is strongly adherent along with the membrane to the nasal aspect of the retina. So here we are using the cutter. You can see the usefulness of the cutter. The cutter itself, it lifts the membrane and cuts it, and there's hardly any traction that you can see except for a mechanical traction that is caused by your own movements. So you have to be very gentle here. Once you identify the plane of dissection, you can easily cut through, dissect the membrane, separate the islands of the thick prolifs, and then eventually cut it. Very important is to quickly cauterize the bleeder, because the blood itself, the blood that oozes on, spreads on the retinal surface and again forms a membrane, which becomes difficult to remove and can cause additional traction. So this way you can see there are multiple islands of prolifs which have been released, and then finally we remove the proliferations, the thick white proliferations, with the cutter itself. In this case, we have not used scissors because the dissection was fairly easy. And then you do a good ablation with the laser in the areas which has not been previously treated. And this is the end result of a good homeostasis with the retina in the center, that is the macula, relieved from all the traction around, no breaks, and the view is clear. This is the ideal end to a surgery. And of course, before you close the case, you must always look at the periphery to see if you have created any breaks in the periphery. and then you either cryo it, laser it, and apply a tamponade. So as I said, use of scissors. This is still used nowadays, despite having great cutter, especially in case of flat and extensive membranes, where you might not be able to insinuate your cutter under a membrane because you might not get a dissection plane. So you have to use use a bimanual technique or a chandelier, so that you can easily lift the membrane with the one hand and then create a plane by gently cutting with the scissor and dissecting it from the retinal surface. And especially in case of membranes that are flat and extensive in detached retina, where when the retina is detached, there is no counter traction. When you want to use the cutter, you're more likely to create breaks because the retina is jumping along with your cutting action. So there again, you use scissors to initiate the dissection, cut the membranes in small islands, and then after that you can achieve your complete vitrectomy. So as I said, the advantages of using scissor, especially when you can do a bimanual technique with chandelier illumination, and you can do a very safe dissection. It can actually be very fast, and it offers more control in membrane dissection. You can even control the bleeder fast because you can quickly use a chandelier along with a you can usually quickly use the flute along with the cautery to cauterize the bleeders immediately. So here I'm just showing you. This is a combined retinal detachment. You can actually see a break. This is a tiny break here. If you had to use the cutter and continue this dissection, you would probably enlarge the break and cause more detachment, and we'll find it very difficult to achieve a complete membrane dissection. There's actually no PVD beyond this membrane, so the scissors dissection actually controls the amount of pull that you cause to the retinal surface, and then you can safely dissect the polyps from the retinal surface in toto. And now after this maneuver, you can actually go ahead with your cutter and do a safe dissection in the periphery. So another very important part of the surgery is control of bleeding, because many a times the bleeding is so much that half your time is spent controlling the bleeding and not applying enough energy doing the vitrectomy. So it's very important that when there's a mild loose, don't do any. There's no need for any treatment because the infusion pressure is good enough to control the bleeding. Sometimes the bleeder is slight when you have cut the polyp, the main nail, the vascular nail of the polyp you have cut, you may have a bleeder. You can just apply gently with your cutter. That can cause the bleeder to stop and clot. The other thing is you raise the IOP. Third is once you identify the bleeder, immediately cauterize it. So all this can happen together also. You can raise the IOP and simultaneously cauterize the bleeder. If the bleeder is extensive, you're just not able to cauterize it, probably because the patient has got, if you look at his monitor, maybe his blood pressure has gone up. There could be, or you have cut the main very large vessel. So you can have a lot of bleeding, and you may not be able to identify the bleeder. So you do a fluid gas exchange, wait for some time, allow the blood to clot on the retinal surface, and then restart the fluid and dissect the membrane. Pre-op, or when you anticipate that this surgery can cause a lot of bleeding, do give a preoperatively anti-VEGF. That allows the vascularity to reduce, and the bleeding usually reduces during surgery. There's a quick dissection, and also post-operative there is a less vitreous hemorrhage. So as I said, what's the role of laser photocoagulation or anti-VEGF injection before surgery? Laser photocoagulation ablates, ablation or intravitreal anti-VEGF injection before surgery reduces the vascularity of the fibrovascular tissue. That helps us in dissecting and gives us a reduced bleeding, and of course post-operative less risk of bleeding. Anti-VEGFs have a rapid action. That's why we very often use it when we have a patient who has a large membrane, a vitreous hemorrhage around the membrane, and you know that this needs surgery immediately, and there's no place for us to do laser. So anti-VEGF have very rapid action. They rapidly reduce vascularity, but they also cause a lot of fibrosis, which increases the retinal traction, and hence we need to do a surgery quickly after an anti-VEGF injection, usually within 2 to 5 days from the injection. Laser effect is very gradual. So if you do have a traction detachment, the macula is just about okay, it is not detached, and you can see the periphery. The best part is to do laser, but it takes a little while, 6 to 8 weeks. The advantage over anti-VEGF is the traction that is induced after the vascularity reduces is very slow and does not cause rapid traction detachment, unlike anti-VEGF. So the indication is usually anti-VEGF is for very vascular proliferation, extensive proliferation without a posterior detachment. This causes fibrosis and contracts fibrovascular proliferation, leading to hilar separation and helps in dissection. So this is the case of anti-VEGF injection is done. You can see in 2 days' time, the left-hand side, it is already lasered, but there was such a large polyp, flat polyp on the retinal surface with very angry-looking vessels. Within 2 days' time of the injection, you can actually see the fibrosis that has occurred. But if you see on the temporal side of this hyaloid, you can see the traction developing. Very quickly, traction also develops along with fibrosis. This is a case where we have done laser. There is vitreous hemorrhage covering the macula. There was no traction detachment. So we did some more laser before we went in for surgery. 2 months later, you can see there is fibrosis. There is less red, more white, but macula is showing some distortion because this is also ended up with a vitrectomy. So what are the post-operative complications that you can expect in the diabetic vitrectomy? Vitreous hemorrhage is the most common complication. Usually 30% of cases will have some amount of bleeding in the first post-op day with adequate rest and good control of blood pressure. This little bit of hemorrhage will usually clear. You just have to counsel the patient. So very rarely you have redetachment of retina. In 20% of cases, when the retina proliferation, whatever polyps that you've left behind, they again contract, or you have missed a break during surgery, which develops retinal detachment. Cataract can progress because usually these vitrectomies are generally prolonged vitrectomies. Takes a little while. Cataract progresses, especially when a diabetic patient, and glaucoma, which is a secondary to the pre-existing what you call new vessel disease. You can have secondary glaucoma. Visual prognosis. The less vision gain that we expect from diabetes can be attributed to the longer duration of diabetes. The longer the duration of diabetes, less chance that more chance that the proliferation has been there for quite some time untreated. The longer interval between development of macular TRD and surgery. Sometimes we see a patient with a macular traction detachment. We advise surgery, but the patient's systemic condition is so poor that it takes a little while for them to get fitness for surgery. In the meantime, the TRD remains untreated, and the visual prognosis becomes poorer. Patient with very poor diabetic control who end up having new insulin for rapid control also worsens the diabetic retinopathy status and eventually causes more ischemia and contraction of the retinal tissue, distortion of the retinal tissue, and poor vision gain. And of course, concomitant ischemic heart disease also worsens the prognosis. So that was regarding diabetic retinopathy. Then we have proliferative retinopathy in retinal vein occlusions. Most often, we have tractional macular detachment or bleeding from a proliferation along either the superior or the inferior arcade where the proliferation has developed secondary to a branch retinal vein occlusion. Rarely we'll have surgery for central retinal vein occlusion with vitreous hemorrhage with or without neovascular glaucoma to control the neovascularity. So surgical principles in this particular case is quite simple. There's usually an incomplete post-vitreous detachment is seen in a branch retinal vein occlusion. Usually the vitreous is contracted and along with that causes traction. So we do have a PVD. The goal is to remove the vitreous hemorrhage media opacity, relieve the traction, and ablate the ischemic retina anterior to the proliferation. Prognosis usually depends, the visual acuity, outcome usually depends on the preoperative visual acuity because we know macular, the branch retinal vein occlusion could have been causing macular ischemia. So ultimately, even if the retina attaches, there's going to be a scotoma, which is there. And incidence of recurrent vitreous damage and retinal damage is usually less than 10%, much lesser than diabetic vitrectomies, because diseases are very localized and not extensive. The other very common thing we encounter is disease, retinal vasculitis causing proliferative retinopathy. It causes, whenever there is a recurrent hemorrhage or a persistent vitreous hemorrhage, we usually advise surgery for such cases. The proliferation in these cases are usually in the mid-periphery, not at the posterior pole, unlike diabetes or a branch retinal vein occlusion. Focal TRDs, like as you see in this side, is more common. And this focal TRDs actually cause a break and cause a rheumatogenic component with a focal retinal detachment. This patient underwent surgery. And again, it's similar to the branch retinal vein occlusion. Incomplete PVD is usually often present. And sometimes the proliferation is at the level of equator. So there can be tractional detachment in the periphery. So again, surgical principles are very simple. Remove the media opacities, remove and reduce the vitreous traction by vitrectomy. And in this particular case, unlike diabetic vitrectomies or branch retinal vein occlusion vitrectomies, we sometimes have to resort to an encerclage to support the peripheral tractional detachment, because sometimes the vitreous cannot be separated from the proliferation up to the aura. So we support it with the encerclage and obviously ablate the retina anterior and anteriorly beyond the proliferation. Very important. Again, visual outcome depends on the level of macular involvement in the TRD and the distortion that is created because of the macular TRD. Early vitrectomy is always advisable in this case for better control of the disease, because the patients usually have recurrent vitreous hemorrhages and can have vasculitis in other sectors other than the areas of the traction. Again, the risk of development of recurrent vitreous hemorrhage or retinal detachment is usually less in this, less than 10%, because the disease is quite localized, focal. However, you can see a lot of distortion that is happening in the periphery. This is a case where traction retinal detachment is there. You can see the proliferation is flat and extends into the periphery. Since it was superiorly, an encerclage was not used, and oil tamponade was used because there was a break in the at the base of the prolif. So in summary, the surgical goal in proliferative retinopathy is the same for all causes. Remove the proliferative tissue, release the retina from the traction, normalize the macular architecture, achieve good homeostasis, ablate the ischemic retina to prevent reproliferation.
Thorough, sir. Thorough, meticulous, and very informative.
Chetan.
Yes, sir.
It is like a textbook. A textbook on surgical retina and the proliferative retinopathy, how we have managed. Really fantastic. So exhaustive. And every detail you have covered. That was
very clear also, sir.
Amazing. It's really fantastic.
Great. Very good.
Yeah.
Also a lot of questions. Four questions have been typed in. Sriram?
Yeah, I'll just have a few points to make. Saravana, do you want to say anything?
Very nice, actually. Very nice for the a little bit described about the conventional 20 gauge techniques like the segmentation, delamination, and block, and the newer conformal delamination, fold back, as well as lawnmower technique. Apart from that, I think it was a very picturesque video, nice videos actually.
We have the luxury of the chandelier illumination these days. I'm sure Chetan will remember. The fellow used to be the chandelier those days.
Yeah.
They had to make
absolutely.
a 4th port and hold the light pipe. And usually diabetic TRDs used to get posted after lunch. So you know what happens.
You have the Alcon infusion light, which comes with along with the infusion, the 20 gauge era. That was the very first. And then when our chief, Dr. Narendran, used to visit the US, he used to bring back this illuminated forceps.
Illuminated forceps.
That was quite expensive, actually. So that was
fellows are very inexpensive.
Yeah.
No, I was wanting to ask, with the chandelier illumination, do you think that illumination a little more diffuse than when you use a light pipe? It is more focal. Exactly, you know, the spot where you want to dissect or something. Whereas chandelier gives you a diffuse illumination. So don't you think it's a little, though of course bimanual you can do, that's a different issue. But the downside of chandelier, I'm just asking for the
But
benefit
sir,
of the audience.
the twin chandelier that Doc has actually better than the single chandelier that we use. That causes more diffuse illumination. Doesn't cause shadowing and stuff like that. Doesn't cause so much of glare. Unlike the ones that we use with our the ones which jut into the vitreous cavity and cause a lot of glare if it is not correctly placed. It may tilt towards the lens and cause a lot of glare, and you might lose your contrast while doing the memory dissection.
Even the single chandelier and dark is very good in the sense you need to put another sclerotomy and put a trocar in it. And one way of getting around what Dr. Mohan Rajan was saying is the single chandelier and dark, you can actually use your assistant to move the fiber up and down so that you can direct it where you want. It's not that diffuse as the other ones. So that way things are moved in a big way. One important point I wanted to stress is, which you had also mentioned, was blood pressure while managing bleeding. A lot of times, most of these diabetics, they bleed invariably because the mean arterial pressure is very high. So it is very important to talk with your anesthetist. I'm sure most anesthetists will be reluctant to give something to reduce the BP, but it is good you have somebody who works in tandem with you to give drugs and keep the BP as low as possible, because a lot of times when the blood pressure is reasonably low, the surgery is actually a breeze. It is usually these uncontrolled hypertensives who also cause a lot of problems, one thing. And the second thing is versus scissors and cutters. When you dissect with scissors, one advantage is actually it doesn't bleed as much as a cutter, because scissors crushes the vessel, whereas a cutter only cuts it, it leaves it oozing. Scissors has a crushing action on the vessel, so it actually, the bleed is much lesser in a scissors than a cutter when you dissect. And the last thing is the PRP. You're talking about the intravit and the PRP. One big advantage of PRP is PRP generally tends to induce a PVD. Though it takes a longer time, it induces a PVD, whereas if you give an intravit, the whole vitreous is just stuck and it makes life much more difficult. And as going by the usual saying, in any diabetic vitrectomy, the more you see the retina, the more problem you'll have. The less you see the retina, meaning the more bleeding is there, which means there is big PVD, the less problem you have. So the more you see, the more problem you'll have generally, meaning the vitreous is going to be very badly stuck. Those 3 points I wanted to make. That's all. Rajshekar, your questions?
Yeah. One question interesting, more a point than a question. He's asking cataract surgery and anti-VEGF 10 days before vitrectomy is a constant practice I'm doing. Will the panel object? That is a point he's making. For every diabetic vit, he is doing cataract surgery with an injection 10 days before. Preemptive.
Can you want to answer that?
Yeah.
Or should combined cataract VR surgeons answer that?
No. We combine the cataract with the VR. We combine the cataract and we give the anti-VEGF about. We don't give about 3 to 5 days is the maximum for us.
Yeah, 5 days.
There
are studies to show that 3 to 5 days is the best time to go in.
10 days is a little too long, I feel.
You start getting fibrosis.
Yeah.
But it's actually not a bad idea doing the cataract surgery and the anti-VEGF initially for 2 reasons, sir. One reason is, yes, you do the cataract and the anti-VEGF. There might be a rare patient where you don't need to do surgery at all. And second thing is actually logistically, sometimes not all people are going to do the cataracts and the VR themselves. So that will be in a different theater, different session, and under topical. Patient is not going to have an local anesthesia at all. He walks in, walks out, then comes for a VR surgery. And some patients, especially if it's a very, very bad surgery, if I expect the VR surgery to be very, very prolonged, I'll prefer to do the anti-VEGF and cataract first, because while doing the VR surgery, halfway through surgery, I don't want my cornea getting hazy. So doing the cataract before, and that way shortens it at least by 15-20 minutes.
Yeah. Here the question was he's doing for every single case. I think that is
that is overreach, I would say. I think you should take this on a case-to-case basis rather than a blanket policy.
Yeah.
So in a nutshell, can you tell me what are the cases you will do anti-VEGF prior to vitrectomy? What are the cases you will not do?
Chetan?
Yeah. So,
you're the master.
So usually I would prefer to give an anti-VEGF only if I'm planning a vitrectomy in that eye, because there is a very vascular tissue there. Despite all my lasers and everything, it is still very vascular. and I don't. I mean, there's no other way to reduce the vascularity of that. I want to do a surgery faster, more precise, and I know there's an extensive proliferation. I'll be spending more time doing this surgery, and just like what Sriram said, that there is a lens which is going to get hydrated, it's going to get problem. There's a cornea which is going to get hydrated. All these things will add to the stress that is already going on. So I would prefer to do anti-VEGF in cases where I'm going to plan a VR surgery. I mean, because there is a very vascular fat prolif. I usually will not give a blanket anti-VEGF for all cases of PDR, just for those cases.
Just to phrase it differently, I would probably give anti-VEGF absolutely in one situation, which is when patient has anti-segment neovascularization. That is one situation I would always give it in. And if there is no anti-segment new vessels, I would give it in patients who are unlasered for sure. Unlasered retinas, if I'm sure the retina is unlasered, I would give. And if there is no view of the retina, I'm not too sure about the laser status, then probably I would err on the side of caution and give anti-VEGF. If it's a well-lasered retina, or I'm the one who's done the PRP, I know how well the retina is lasered, or I can see the prolif and it's absolutely avascular, I don't think there's any need for a blanket anti-VEGF for all these patients.
Do the patients position themselves post-surgery? Diabetic pits, do we need to position? That's a question. Probably is asking
any
semi-reclining.
vitrectomy with a tamponade needs to position, irrespective of the indication. Any vitrectomy with a tamponade.
He's not meaning the tamponade, Sriram. I think the meaning is like any diabetic vitrectomy which has been done, do they just go for the supine position or do they take a semi-reclining posture? That's what he's asking, I believe. That's what he's.
The moment, because these days it's very unlikely you leave BSS. You hardly leave BSS, because even if you don't need a tamponade, for more efficient closure of your sclerotomies, because of higher surface tension, you do a partial FG at least. And if the patient is phakic especially, even if you leave air in the vitreous cavity, if you make him position supine, you're going to increase his chance of cataract formation. So any tamponade you leave behind other than BSS, I think it is best to posture.
Posture,
whatever the situation may indicate. It need not be a prone position. It may be just sitting up erect or lying down on the side. It need not be a strict prone position.
In the process of a diabetic vitrectomy, will peeling be done? Do you do a ILM peel?
ILM peeling
in a diabetic vitrectomy?
I would be very, see, that's what it's again, it will depend on how the macula was preoperatively. This very shitic macula, I would probably not peel and cause more breaks in the center of the retina, and it will come as a piecemeal. But yes, if there is a prolif on the disc, there is a second membrane. Usually there'll be a very fine, thin second membrane. So there's no harm in going for the ILM peeling. That makes sure that even that particular second membrane also goes away and the macula is clear of all membranes. So doing an ILM peeling is case-to-case basis. It's not a blanket ILM peeling that you do for everything.
In a way, you ensure there is no hyaloid stuck on the macula.
So there's no hyaloid which is stuck on the macula, which allows a reproliferation to occur on the macula and causes contraction of the macula again.
And additionally, if there is maculopathy, if there is diabetic maculopathy, or ILM peeling might help. Like one of our teachers said, more often we peel ILM because we can peel ILM than we should peel ILM.
Alternate day dialysis. This set of patients, how to handle alternate day dialysis? Probably he's meaning CRF, diabetes, CRF, alternate dialysis,
thrice a week dialysis. That's the maximum you can go.
So usually they have the dialysis the previous day and they come next day for surgery. Next day for surgery. That's the best thing to do. And they usually they won't stop any of their medications. We don't advise it as well.
You suggest heparin-free dialysis for them?
Yes. Our residents generally ask them to get a heparin-free dialysis just so that the rare, but that actually doesn't cause so much of bleeding. I've never seen
heparin acts only for 6 to 8 hours.
Very short duration.
So even if you're going to use heparin in the morning and you operate in the evening, there will not be any difference, and invariably operate only the next day. So that really shouldn't cause a problem. And an alternate day dialysis actually is not a big problem, because if he has dialysis yesterday, he's going to have it tomorrow. The problem is in those people who have dialysis once a week or twice a week, or even once a week are the biggest problems. So you should do surgery the day right after dialysis for those patients.
Yeah.
If you're going to do the surgery the day just before dialysis, by the time his creatinine is shot up and the fluid overload is reaching his limits, intra-op he'll go into pulmonary edema.
Exactly.
So never go up to the day of dialysis and do it just before you land up with systemic problems.
Yeah.
Don't really
And,
fear that heparin that much because it works only for 6 to 8 hours.
Yeah, simply,
If at all
the
anything,
only,
you will tend
yeah,
to
only
fill
in
in
this,
oil on those cases because they bleed. Because they're going to have heparin again and again.
only the heart patients that we don't stop the heparin, they generally shift to the shortest acting heparin, but then we can't stop it. There's
Can't
something
stop.
you have to.
See, very
Yeah.
next day he's going to have it. If he doesn't bleed on table, he's going to bleed the next day.
What
Yeah, he's gonna
about
be
what
the next
about the regular blood thinners? Like aspirin, clopidogrel and all that?
As aspirin and clopidogrel, there is no clear-cut data to stop
Yeah.
them. So we can very well use them. Only when you are using warfarin, initially we used to switch to heparin, but now they say you check the INR values on the day of surgery. If it is less than 2, 2.5, no problem, we can go ahead and do it. If it is 3.5 and above, 3 and 3.5 and above, there's a higher risk of intraoperative bleeding. But even then, they say that the final visual outcome is not that very different from the even it's a low threshold also. So anything less than 2.5 INR on the day of surgery is fit enough.
Yeah.
If at all anything, the risk of retrobulbar or a peribulbar is higher than in surgery. With patients on anticoagulants. Like
we
Always we used to
dabigatran.
switch all the warfarin people to heparin before we take up surgery, but now we no longer do that actually.
Yeah.
Because of subtenons,
We
it's much
stop,
safer.
Saranan,
Sir?
we stop the blood thinners about 5 days prior to vitrectomy or
So
even
truly
glaucoma.
speaking, sir,
Only for
the
cataract, we
blood
don't
thinners,
stop.
to leave the system, it takes at least 2 weeks. Sir. 3 to 5 days hardly makes a big impact. For the full drug to clear the system, it takes at least 2 weeks.
So there's
it
no need to stop, is it?
doesn't
For
matter.
antiplatelets, no surgery, ocular surgery, intraocular surgery, you need to stop.
Aspirin and clopidogrel, no need to stop. Even if you stop, the full effect takes at least 2 weeks to go up the system.
Anticoagulants for cataract, no need to stop at all, sir. For VR,
No. Cataract, we are not stopping.
okay. For VR, well, it's
For glaucoma and vitrectomy.
Anyway, when we get a cardiac witness, that cardiologist writes for all these things. He
that's
writes
because he doesn't know.
Cardiology will write all
2 days
5
later.
to 7
Yeah,
days.
standard.
I have a blanket advice.
So what he has written, we
No,
have
but
to
he
obey.
doesn't know what we do now. That's why.
Yeah. True. Probably he thinks
He
like a
compares
general
ours to
surgery.
open abdomen surgery. That's the problem.
Yeah, like that. On a scale of 10, how many cases silicone oil? Probably a cheeky question. That's what he's asking. He's saying, like in 10 diabetic bits, how many will end up with silicone oil? That's what he's asking.
It depends
Maybe
upon
50%.
what type of cases you
On a
take
case-by-case
practice.
basis. In Saravanan's hands, in a rough thumb rule, how many will be, Saravanan?
Rough, probably you can make it as 40% of the load.
Yeah, 40%. Chetan, your number?
Same. 50%.
40%.
Maybe 30 to 40 maximum.
30 to 40. Yeah, great. Done. I think
Madan, any inputs? Madan, you've been
just beyond the purview of this lecture, I just want to ask a question to all the panelists here and speakers. We have a patient with a well PRP dye. There is no traction. Vitreous hemorrhage is not clearing. Okay, can we give an anti-VEGF?
Provided you have done a proper laser and this is a well laser dye with
well laser dye.
Well laser dye with
no
no
traction.
significant fibrous tissue, then probably the chance of inducing traction following avastin is less. In those cases, when there is a recurrent hemorrhage, you can give. But you should understand that the effect of avastin or lucid is going to work for only a few months, and the chance of recurrence after that is still there. It's not going to once and for all take care of all the pathology. That you should keep in mind. It's a transient effect.
No. Once the hemorrhage clears, probably we can do some fill-in PRP.
Probably.
Yes.
So you have to keep that in mind. It's not a standalone treatment. That's what I wanted to push into your knowledge.
No. That's right.
I don't remember the exact alphabet, but there's one DRCR protocol which compared intravitreal injection in vitreous hemorrhage. It did not really find any significant advantage of giving intravitreal injection in the presence of vitreous hemorrhage towards clearance of hemorrhage.
It's not going to clear, definitely. It's not going to make it clear. Probably you can keep the new vessels inactive till you get your full laser inside. That may be the aim of.
No, I have seen some couple of cases where the vitreous hemorrhage is cleared. Not very dense vitreous hemorrhage. We're talking about a very mild
No, sir,
vitreous hemorrhage.
So that will
avastin
clear
is
with
not going
Retina also,
to
sir.
make it clear. It's going to prevent recurrence only. It's not going to make the hasten the process of vitreous clearance, hemorrhage clearance. That's not going to happen.
Actually,
And one question,
I prefer to give Avastin, or the anti-VEGFs in cases where there is a very fine new vessel disease on the disc.
Yes,
You
without
ablate it
fibrosis.
as much as
New-
possible,
Yeah.
and or you have new vessel disease so close to the macula, there's nothing more you can ablate, and it comes back for recurrent vitreous hemorrhages. Those are the cases where I would probably stabilize the patient on
you
anti-VEGF
cannot
because
do
of
any
the
more laser
regress
to
you do.
regress.
Yeah, and even if you do a vitrectomy, you're not going to take care of that one small new vessel on the disc.
Yeah.
So that anti-VEGF is actually a good idea.
Another question to panelists. Anybody is the thoughts on giving anti-VEGF at the end of vitrectomy? Some people do it. I don't.
I do it. When I feel that the surgery is quite traumatic and the chance of recurrent hemorrhage reproliferation is high, I usually give. More severe the
It hardly
disease, more
lasts in
severe
the
the surgical intraoperative course, how it was, I sometimes give. I mean, quite often I give it actually.
Very good.
My catch this thing is it hardly lasts in the eye for a few days. So
Possibly. So there was one sort of theory was why sometimes if we give like a preoperative Avastin to counter the vascular, what do you call it, event, and then once you clear during vitrectomy, you clear of all the drug, there's a rebound chance of hemorrhage. There's also one theory on that. So sometimes I give it on table also.
Superb, sir. Madan,
Okay.
your last words. Madan will get the last final.
invite Madan for his closing remarks and vote of
Madan,
thanks.
over to you.
Thank you all, sir.
Madan, you're the only one with a head full of black hair in this panel.
So I'm actually
I'm also.
So I was really enjoying the enriching talks, discussions, and all. I've learned a lot, sir, in this thing. I'm truly thankful to everybody who participated in the discussions. So it's a privilege to give the word of thanks, and first and foremost to Tnoa, our dynamic president, MR sir, who always pushes us and helps us to do things in a better way. Our office bearers, our energetic ARC chairman, Rajsekhar sir, HOD Madurai Medical College, Dr. Vijay Shanmugam sir, he was here and he had to go out for other commitments. He actually logged in spite of his busy schedule. He's not in town today. He's traveling to various places for inspection. So in spite of that, he took out time to join us. Thanks to him, sir. And my sincere thanks to Saravanan sir, Mahesh Shanmugam sir, and Chetan Rao sir for accepting the invite on behalf of Tnoa and being with us. I'm sure all of us have learned a lot today, just as I did. They're all my teachers from whom I've learned the art and science of VR surgery. And truly, it was such a privilege to, be able to listen to them and refresh my basics as a student. Very, very enriching. Thanks to Milmet for putting all this together and providing us a platform. The enthusiasm and support of their entire team was just impeccable. Finally, I thank all the audience for joining us today, for providing their inputs, for raising valuable points, contributing to the discussion. And it was all in all a very, very good 2 hours, I would say, well spent. I look forward to meeting all of you in such meetings in the future. Thank you all. Thank you.
Thank you all.
Thank you. Thank you,
Good
Madan.
night.
Sir, 2 more to go.
Rajsekhar.
Yeah.
We have the walk the talk and looking forward to seeing you all in Europe tomorrow for the physical meeting. And of course, one more TNOA Connect series on 31st July.
Yeah.
But more importantly, this is the last ARC PG Catalyst Masterclass.
PG Catalyst.
And we always have the best for the last. And we have got the best for the last. And we have got the best speakers, best panelists, the best session ever.
Yeah.
It's really fantastic.
All because of the best president.
Hats off to all the speakers. Wonderful.
They're all because of the best president.
Really, we are at 10 o'clock now. It's almost 2.5 hours. It's long time.
Fantastic. It is really fantastic. The YouTube recordings will be there very soon, by tomorrow. And we have to thank Milmet for supporting this and powering this. Himanshu is there. Ketaki, Raju. Don't forget the Osiva they've introduced.
Yeah.
Which has been very cheap, very effective. I started using it already. Very effective. I think you should try this Osiva. Okay? And these are my closing remarks because Millimet sponsored all the 14 PG master classes. And of course, Mega Brom and Glow Eye. Thank you very much.
Welcome, sir.
Thank
Thanks
you.
a lot for everybody.
Bye,
Bye,
sir.
Chetan.
Wonderful.
Thanks, Saravanan.
Bye, sir.
Wonderful.
Thank you, Saravanan,
Bye,
sir.
sir.
Thank you, Chetan, sir.
Bye.
See all of you in Coimbatore.
Yeah.
Right. Definitely.
See you all in
sir.
Coimbatore.
We'll meet.
Yeah.
And
Good
see
night, sir.
Madan and Rajshekar, are you coming to Europe tomorrow?
No, sir. No, sir. No. I'm
I'll be
here,
there.
sir.
Madan,
I'm
please
here
come to
next
Europe.
time. Next time.
Sriram, you also come.
Sure, sir. Sure,
Thank you,
sir.
sir. Good night.
Right.
Thank you, sir.
Ivanshu, we'll sign off.
Thank you, everyone. So can I end the meeting with your
Yeah,
permission?
yeah, please.
Yeah, please.
Thank you.
Thanks.
Okay, so we are ending.
Is that Ketaki there?
No, sir. Aarti is here from Imagica Health.
Oh, thank you very much. So nice.
Thank you, sir. It was great session with you. Thank you,
Please
sir.
send the recording to me tomorrow.
Okay, sure. I'll share, sir. Thank you.